Bwrdd Dda pawb, a croeso I gyfarfod Bwrdd Iechyd Prifysgol Hywel Dda. Welcome everybody and to today's board meeting. Mis Medi yn barod, September already. You'll note that we are starting the board meeting earlier today, and that's because we have the AGM this afternoon once we've finished our in-committee session. So we need to budge up a bit in terms of starting a little bit earlier. We've got some really meaty, chunky items to talk about today. So and we need to make sure that we're giving it sufficient time and consideration before we make the appropriate decision. Before I start, just to confirm, did everybody receive their papers in good time? Great. Were they clear and comprehensive? And is there anything that members feel have been omitted from the papers that we might need to discuss today? I'm taking your acquiescence to mean no, there isn't. Great, okay. As ever, when we come to make decisions at the board, it's really important for all of us to be consistent in the way in which we make those decisions, and we work with a set of design principles. Those design principles ensure that when we think about making our decisions, we are fair in terms of the impact of those decisions. Those decisions are affordable and sustainable in the medium and long term. They are consistent with our strategy, so they align with what we're trying to do in the long term. They do not create an unhelpful precedent, which will either cause us to have to make other decisions of a similar nature in the future. And fundamentally, they're driven by the principle of needing to be safe in terms of the services that we deliver. Great, okay. Can I begin by taking apologies?
Yes, thank you, Chair. So we've got apologies from Andrew Carruthers, our Chief Operating Officer, and he's represented by Gareth Cottrell, our Deputy Chief Operating Officer. We've also got Jonathan Archer, who is the Chair of the Health Professionals Forum, and Mwapi Burke, our aspiring board member Chair.
Great, okay. I can't see Mwapi around the table.
No, sorry, we've got more apologies.
She's apologised.
Yeah, sorry.
Okay, great. And then we have a number of other individuals attending during the course of the day.
We have, Chair, yes. Yeah.
Great, okay. Can I ask if there are any declarations of interest or conflicts of interest? If no, shall we then move on to preliminary matters? Let's begin with the minutes of the public meeting held on the 26th of June 2025. Are we happy to approve those minutes? Yes, I can see nods around the table. Let's approve those minutes. Let's move to the minutes of the public meeting held on the 31st of July. Thank you, Claire, for completing a accurate and clear set of minutes. If everybody's comfortable, let's agree those minutes. Let's move to matters arising. So, are there any considerations we need to think about in relation to our matters arising? I think a number of the items will appear in the report. I did have a question around the first matter arising, which I think is in relation to the Peninsula Group attending the board in January. I think we've now revised that date, if I'm not mistaken.
Yes, Chair, we're working with the group to, it'll either still be January or March. We're just waiting for confirmation from the group.
Very good. Eleanor will be chairing the meeting in January, and I'm really keen to be part of the conversation with the Peninsula Group. So I'm pleased that we've been able to delay that. Any other considerations in relation to matters arising? Okay, let's move to report of the chair, my report. Are there any questions that you would like to ask, or any points you would like me to address? This is all going very well. Great. Okay. Let's not dawdle. Let's move forward. We've got such a lot to do. I knew that would happen. Rodri.
Cadeirydd, just poor blocky ward Larry, so the Larry Cancer Unit, kind of in the finals on the 2nd of October. So poor blocky, poor beer.
Indeed, and bendant. Fantastic. Let's hope that they're successful in that. Very good. Let's move then, with your support, let's move to report to the Chief Executive. Phil.
Diolch, Cadeirydd. So there's a fair bit in this report. Obviously, take it as read. I did want to highlight the item on the Ceredigion Community Mental Health Service, the fact that we're asking for an extension to the temporary change until November 2025 because of the additional work that's needed around that. It may be that there are questions around that. The other areas I wanted to highlight were particularly around the ambulance handover work. I think I want to draw in Gareth Cottrell on that because there's been a significant amount of work on our ambulance handovers with some really what are early signs of improvement. So our ambulance handovers have significantly improved in the last few weeks due to the incredible work of our teams, not only in our hospitals but also within our communities. And what that's meaning is that the ambulance response times are improving in this area. So that's I'm sure something that we as a board really welcome because it's been a concern for us for some time and our population. And also it means that some of the staff experience in our A&Es on some days is improving when things are going well. So I think for the first time we've seen a really significant step change. I think the challenge for us will be making that sustainable, and we're putting a huge amount of effort into that. The other areas I just wanted to briefly highlight.
I just wondered if you wanted to invite...
Yeah, I can pause there. Yeah.
Invite Gareth to say anything else in relation to that.
Yeah, thank you, Chair. I think the first thing to be noted is this work probably started in essence around about 4 or 5 months ago, and it resulted from what I would call a kind of laser-like focus from the Chief Executive and the executive team with regards to patient experience within our urgent and emergency care system. So we've built on that desire to improve our experience for our patients and our outcomes for our patients. And that's sort of culminated in some work during the month of September, during this month, where we had what we call a reset week. Now, we've had reset weeks in the past within the Health Board, and they haven't been so successful. And what we've learnt from previous experience and what we've taken is learning from across Wales and across the UK in terms of what works, what doesn't work. And we've incorporated that into a much more focused reset week where we've targeted our entire system as opposed to on previous occasions where we've looked at perhaps an individual hospital. This has been clinically led with a clinical focus and a real focus on our patients and what's right for our patients, and ensuring that we as a health board system own our patients and are putting their best interests at heart. What we've seen is I think a step change in improvement in terms of handover times, which in turn, as colleagues will know, that means if we hand over our ambulances faster, it means that the ambulances themselves are out in the community to address the next emergency patient who needs our help. as Phil has mentioned, staff experience has benefited from this. There's a real uplift in morale within some of our urgent and emergency care teams. There's a note of caution. It's early days, and we're working extremely hard around the sustainability of maintaining this now, particularly as we head towards October and the 45-minute handover requirement from the Cabinet Secretary, Welsh Government. So the signs are positive. In terms of the sustainability, what we've used our reset week and subsequent weeks for is to empower our staff to work to the top of their licence, which is a really important factor. And it's from my perspective, it's really fantastic to see the support I'm getting from the executive team, from the clinical executives, especially Phil and others, around sharing a message within the organisation about this is how we want to operate and this is how we want to provide better quality services.
Okay, I think the board we would acknowledge the fantastic work that's been done, not just within the last week or two, but in terms of the focus on urgent and emergency care. And to thank everybody who's been involved in doing that. It seems to me there's been a real shift in terms of what people have been able to do and how they've delivered over the last week or so. And we are delighted to see that. That is a fantastic step forward. And I accept what you're saying, Gareth. It's fragile, and the real question is sustainability. But if ever there's a demonstration that actually an organisation coming together at a systems level can really deliver high impact over a short period, we've demonstrated we've got some of the core skills to do that. And I think that's an excellent step forward. Thank you very much. And thank you for your help.
Yeah, and I think actually that's a really good point, because for us, for many years now, we've struggled to have that kind of impact. And so there was a bit of a question of, do we have the confidence that we can make that difference? And it really has shown exactly that by working together as a system with the kind of clinical and managerial leadership that we're seeing from Gareth and others. We can make a difference. The other point, Gareth mentioned the 45-minute ministerial advisory group target, but I know that Gareth and colleagues are working to what the actual standard is, which is a 15-minute handover. So that I know, Gareth, because I've seen you in action on this, that you're holding us to that 15-minute target, which actually, if you're in an ambulance, if we think about the patient experience, you don't want to, the shorter time you can be in an ambulance outside a hospital, the better, and the quicker we can get the ambulance out into the community to people in need, the better. So and everybody is straining every sinew to make that happen. So the other points in the paper, if you're happy for me to move
Indeed,
on, is that the Healthier Midwell strategy, you can see there's an update there with some slides. I know Lee would be happy to take questions on that proposal, that we do some engagement with the public there. We do need to progress that. We know that the strategy does need a refresh. We agreed it back in 2018, so that is an important piece of work 7 years on. The clinical services plan update, you'll see there this really fundamentally important piece of work that we've been undertaking. We're seeing the fruition of that work now coming to show. You'll see in the paper that we've had a huge amount of responses and we've had a large number of alternative options proposed, and we are asking to extend the time period for when we come back. It says in my paper, the recommendation back to board in January. Actually, since the paper was written, I know we've been in discussion, and we want to set aside a separate board meeting in February to have that discussion, so that is the proposal. It's not actually January. There is an advantage to that because we will have a sort of one issue board on the clinical services plan, consultation output. The other areas you'll see just that we will need to, we're asking to agree to the collaboration agreement between our health board and Carmarthenshire County Council around the hydrotherapy pool for Pentre Owl, but there'll be colleagues who can give more detail on that if required. But otherwise, I'm happy to take any questions. Cyhoeddus.
Colleagues, questions? Rodri. Rodri and then Maynard.
Diolch yn fawr Cadeirydd. Un cwestiwn i'r Prif Weithredwr. So back to the ambulance handover preparation and just kind of me being a bit inquisitive perhaps, but the 45-minute handover, yes, you've had that system reset week. I just want that reassurance really that getting that handover and doing everything within that time slot, yeah, there won't be a backlog of perhaps patients in corridors kind of, and perhaps not being dealt with because the staffing hasn't changed. The amount of people that will be coming into the hospital won't have changed. So I just want to have that assurance that there isn't that kind of, we're trying to hit this target, but then patients are going to be on beds in the corridors. So just have some assurance.
Yeah, thank you, Rodri, and you're absolutely right. Our focus has been on not to move the problem or the risk further up the chain, shall we say. We know that other health boards, when they've tried to tackle this problem, that has become a risk. So we've been acutely aware of that. And I think what we've managed to do, ensuring that this is a clinically led process, we've been able to target some more senior decision makers at the front door, so in ED. So if we're making the right decisions for the patients in the first instance, we've been able to avoid some patients being admitted altogether because we do have, where appropriate, other alternative services that may be able to provide the care that they need. So we've been having a focus on the entire pathway, and that includes the wards, the way in which patients are, I say managed on the wards, the way their discharge plans and their discharge processes are managed. So right through to the point where our discharge lounges, we're ensuring that those patients who are ready for discharge that day arrive in the discharge lounge far earlier, prepared and ready to go, which frees up the bed to create the flow within the system. So it has been very much a whole system approach with quality and safety at the absolute forefront. We sort of took the decision right at the beginning as an organisation that to do anything that either compromises or doesn't improve quality and safety is not somewhere where we wanted to go. I hope that provides the assurance.
Thank you.
Thanks.
Great, okay. Maynard, and then I'm going to just, I'm just conscious of time. Winston, you'll come in, and then I'm going to close the item, and we're going to just take the actions at the end of it. Maynard.
On the Charitable and Community Mental Health Service, I'm conscious that there's a paper going to QSEC in October on this, but I'm just concerned, November's only 2 months away. Are we holding ourselves to fortune by just extending it to November, or should we be looking for a longer extension at this stage rather than having to come back possibly in November and ask for another extension? And my second question concerns Pentre Owl, as mentioned in the exec team discussions, that we're looking at additional accommodation there. And I remember a discussion not that long ago where we were discussing the financial consequences of our current commitment to Pentre Owl and the affordability of that. And I'm just wondering if that's changed.
Good questions. Winston, did you have a question?
Yes, please. Thank you, Chair. On the Pentre Owl thing, I just think the paper doesn't convey what a remarkable achievement it will be. It doesn't set out when we're likely to achieve it or make it happen. But I wanted to comment on that. It's such a great working between the organisation, local authorities and the private sector as well. I think that's commendable. My question is on two things I want to comment on. I want to comment on the ops structure. So I welcome the exec team and making sure that they've completed phase 1 of the ops structure. It's something that was mentioned in the audit committee, ARAC. Yeah. So we recognise the response there. Want to find out when phase 2 is likely to be completed. And finally, on the strategy refresh, which I welcome, I like the fact that we're talking about not where but who. And in particular, in relation to that, I wondered, we're already getting a huge amount of public engagement. We've got 4,000 responses in relation to the clinical services plan and stuff. And also we've got the strategy refresh coming. I'm just wondering about our capacity to enable us to respond to the public in the right way. When you get something like 4,000 responses, not everybody can be happy. So we're going to have to be quite careful in the way in which we respond to those those responses which we just simply cannot respond to.
Which is why I think we've decided to create an extraordinary board meeting on the 19th of February, Winston, precisely so that we can fully understand the broad implications of the clinical service plan and what people have said to us.
Yeah.
My feeling is we can't manage that within the context of a single hour on the health board. Our agendas are so busy. So, very good point. And both points very good. And so I'm going to come to Gareth, and then Lee, I'll come to you on the Pentrawl issue. Gareth, just to respond to the North Ceredigion mental health service issue.
Yeah, and I might invite Jill as well, because so I think what we've learnt in the past months is, whilst we've put this temporary service change in place, we have been liaising with multiple stakeholders. But I think there's more we can do. I think it's fair to say. I think there is some more dialogue that we need to have between myself and Jill and with some primary care colleagues. I think it's fair to reflect that. In terms of the question with regards to the 2-month extension, and I think it's, if I sort of paraphrase it, I think the question is that long enough? I think it's felt that by November board, we will be in a position to have been able to have taken views on board, to analyse data, analyse feedback, analyse the impact of the temporary service change, and be in a position to start describing what the solutions can look like and the way forward. I don't know, Jill, if you wanted to come in.
Yes, thank you, Gareth. And I think I just want to reflect that all of our conversations have been taking place with the service as well around this. But I think more than the consideration around the longer term implications, I think it's really important to make sure that we're continuing to use or rely on that temporary arrangement. And that temporary arrangement relies on general practice quite heavily. And I think there's just been some feeling this week particularly that GPs feel that there are some lessons to be learned from the process that we've taken far so forward, and if we are extending it to November or beyond that, it's really important to get the GP's understanding of what's been going on, how well it's been working, so that we can make any early changes to the temporary arrangements to help us to get that best service in place as possible. So I know Warren and the team are going to be doing that. They'll be making contact with the cluster leads, as Gareth said, so we'll have some more conversations with the GP so that we can support that temporary arrangement whilst that longer term work is ongoing. So thank you, Gareth.
Great, okay. I mean, just to close that item, good question, Maynard. Well, let's work to November, and if what we find is we haven't completed that sense of consultation, wider consultation, or been able to fully explore the implications of the current service as it exists, then we will address that in November and think about it then in terms of moving it forward. But at this point, I think what we're saying is let's work to that November deadline as much as possible. Great, okay. Lee, I'm going to come to you on the Pentrawl issue, and then I'm going to come to Lisa on the organisational structure Marta.
Yep, thank you, Chair. So, yeah, it's a fair question. So we know we had quite a lot of discussion previously around Pentrawl, and we had to reduce our floor space as part of the original agreement to make it fit within what we could afford from a revenue perspective. So that the point there and the reflection in the exec discussion doesn't change that. We've still got we're still very cautious about committing further costs in that way, but what we are aware that there is additional space available, which I think therefore it's appropriate for us to explore that, and at the moment it's very much an exploratory piece of work because it could give quite significant opportunities to us, recognising that we have a number of accommodation requirements in the Llanelli area, and obviously it's going to be quite transformational for the town. So we're looking into that. There are a number of options which we could pursue that would reduce some of those revenue costs if we were to end up in that position. But obviously we'd come back to board at any point if we were of a view that that was the right thing to progress with. So at this stage it's very much exploratory, and then we'll come back when we've got a further view on it. If I could just comment briefly on Winston's point on CSP and strategy refresh. So in addition to the 4,000 plus responses we've had on CSP, we have had 627 responses to our question on the strategy refresh, which is very positive. Given that we were doing all the other work as well on consultation engagement. In addition to that, the Health Board initiated an All Wales YouGov survey where we've got further insight into the views of our population. So we've had over 100 responses to that from our local population. So we've analysed that and drawn the key themes from that, so that can help us with our strategy refresh work. You'll see from the slides that what we're intending is really to continue with the continuous engagement approach we've taken to date. So we're not producing big chunky documents that obviously would take us quite a lot of time to produce, and the capacity issue that Winston's referencing certainly would be a concern then, where what we're trying to do is seek out all the opportunities that we can to have a richer dialogue with people and our populations to help get us into some of the questions that we've posed on the slide. So it's I guess it's our first attempt at moving to that continuous engagement approach, and we'll continue to do that as we progress through the strategy work. Which
we are very keen to do as a board, not have these constant one-offs, but grow a long-term conversation with our communities. Thank you. Mena, just for your assurance, it will need to balance off. Yeah. So any benefit in terms of any costs associated with additional space at Pentrawl will need to balance off against the benefits, or where those costs can be distributed or underwritten by other cost savings. Yeah. Great. Okay, Lisa.
Thank you. So the organisational structure was part of the conversation we had in People and OD Committee at our last meeting, and the Chief Operating Officer gave a commitment in our November meeting. He would be sharing the final structure along with progress that will have been made at that point in terms of aligning people into the new clinical care group structure. So there will be an update in our next board.
Great, okay. I'm going to take us to the recommendations associated with the Chief Executive's report. So at this stage, approve the extension of the temporary service change at Charitable Community Mental Health Service. Is the board content to support that? Great, okay. Approve the clinical service plan consultation outputs being presented not in January but to the 19th, on the 19th of February. Great, and agree to the collaboration agreement between the Health Board and Carmarthenshire County Council for the hydrotherapy pool at Pentrawl. Great, okay, and then obviously noting the strategic refresh strategy. Thank you, Lee, for the additional information. Note on the corporate risk register and endorse the register of ceilings since the 31st of July. And then note the status of the report for the consultation documents received in Appendix 4. And also note executive team discussions, which just to report back, I find that really helpful. to understand the scope of what's being discussed in executive team meetings.
Yeah.
Great, okay. Let's move to our next item, which is delivering on our purpose, quality, safety and performance, and to our annual plan. Lee.
Thank you, Chair. So I'll be relatively brief in the introduction to allow any time for discussion, and we are, of course, at an interesting point now, midpoint of the year, and reflecting on progress to date. So we since we agreed the plan in March, we've made quite significant progress in a number of areas, and obviously we'll pick that up in the respective papers. What we have seen is increased Welsh Government expectations. Gareth referenced some of that just now, and a series of correspondence from government and from ourselves as well in response to that. That has required us to reflect and revise some aspects of our plan, and obviously there are expectations that we progress further in a number of key areas without then negatively impacting on any other objectives that we've set. As a reminder, we went through quite an extensive process of developing the plan over a number of months, and what we were seeking to do was strike the appropriate balance across different domains. So quality, access, finance, for example, it was quite a delicately balanced plan given the range of challenges that we face as an organisation. So therefore, any change in that balance does need some careful consideration, and the following paper on the financial choices describes the process we've gone through to respond to Welsh Government's expectations from a financial perspective, going beyond obviously the financial control total that we work towards as part of the plan development. Given the evolving expectations, we've used the paper today to just summarise those changes to date, so board are aware of the overall picture and have that overview, because obviously that sets the direction for the remaining 6 months of the year, but also heading into next year. Then the other couple of points I'll just make briefly. As is the midpoint of the year, we have already commenced work on developing the plan for next year. So the paper sets out our overall approach to that, and we will have an opportunity in October board seminar to get into that in more detail and spend some time on that point. And then finally, what we are proposing in the paper, you'll note, is an amended approach for future board papers. So the intention there is to try and remove duplication or avoid duplication and streamline the agenda. So I'd welcome board members' views on that approach. Thank you.
Okay, yeah, I'll give you an immediate assurance. Board members welcome the opportunity to streamline some of these papers. And actually, the suggestion, I think, is a clever, intelligent way of making sure that we look at something once as opposed to 3 or 4 times. I think that's a really important thing. Thank you very much. Colleagues, thoughts or questions? Chantal.
Diolch. Thank you, Chair. And I was just wondering, in terms of the annual plan, I can see there's lots of plans, but is there a timeline for the delivering of it? You know, the implementation of all of the things that we're saying we're going to do in order to achieve meeting up our responsibilities in terms of the deficit.
Okay. Well, my view is annually. So at some point we've got to, it's aligned to obviously a financial year. So fundamentally, we would have to do that unless Leah has other views. Or
Well, no. So we've got obviously within the plan that we agreed in March, we've got very clear deadlines for this year, and next year's plan will similarly set out the timelines that we're working to. One thing we are keen to do for next year's plan is make sure that we're sufficiently describing what year 2 and year 3 could look like. So we're describing more of a route map to delivery. We've obviously got some expectations in year in relation to the financial position, as you know, in relation to the point you picked up. And then beyond that, we're in the process of developing a 3-year roadmap to try and describe what it would require for us to get to a break-even position, which is obviously our ambition. But Hugh may want to comment further on that.
Hugh, I'm going to hold you a minute because I think we'll come back into that in terms of your financial report. I'm just keen for us to move on. Eleanor Maynard.
Thank you for the paper. It was incredibly helpful to see the differences set out between the original plan and what we're now asked to do. My question and comment is I really welcome the fact we've embraced these, and they are ambitious changes. Are we sure the organisation is going to get there is the question. And I think my feeling is with the exec team and a fair wind, we are all set to do it. It's ambitious, and I'd just like to give my backing to the execs to be able to do that.
Great, okay. I think we'd share that ambition as well, Eleanor. Very helpful. There was a question lodged in the middle of that about whether it's deliverable.
Yes, there was.
I suspect execs have a view on that.
It was the silently killer question, I'm afraid.
Indeed. Before I come to Maynard, it seems to me, essentially, we engaged in a heroic exercise, which roughly began this time last year, to agree our annual plan. A very good plan, I think, based on what we felt we needed to deliver. Subsequent to that, we've had a whole series of external imperatives that says, thou shalt, and suddenly we find we're having to deliver against a much broader framework, certainly within a tighter financial envelope. We're having to deliver against a set of different imperatives in terms of our performance, which kind of changes the plan and ups the ante a little bit when we start to think about the plan. Now, it doesn't negate the fact that it was a heroic effort last year to pull that plan together, very considered and very detailed. It partly reflects the fact that a plan only works, when you're operating in a very stable, consistent environment where you can predict those long-term changes. This year has been anything but. So there's something about how do we incorporate a high degree of flexibility and adaptability into the planning process, which would allow us to kind of deviate or concentrate or accelerate where we need to around a number of core issues. But I think that certainly came through in the plan for me. I'm going to come to Maynard, and I think the boss wants to say something.
Yeah, well, my question follows very nicely on from what you said, because Lee acknowledges in the paper, and again, great paper, and really glad that we've already started looking at how we pull together next year's plan. But you actually say, when these requirements converge with an already stretching programme of financial recovery and performance improvement from challenge baselines, they collectively require careful sequencing, prioritisation and organisational capacity. And it's that organisational capacity that concerns me, because within some of the savings areas we flag that the strategic planning staff might be frozen, and delivering a plan that is set out in a stable environment, the resources. When it's a moving target, it gets increasingly difficult, and you need the capacity to be able to change that plan and adapt that plan to the changing circumstances. I'm just wondering how we balance those two things.
Good point, Maynard. Good point. Phil, do you want to?
Yeah, diolch, Cadeirydd, and thanks for the questions. I think just relating to your point, Eleanor, I suppose whilst our control total was 31.5 million deficit, our outturn was 24.1 million last year. And we do need to remember that the additional funding we had last year, which was to address an allocation, to make sure our allocation was similar to other health boards, but it was contingent on us getting to balance within 3 years and making progress towards that. So I think it should be no surprise to us as a board that from a government perspective they would be expecting us to make progress towards that balanced position rather than expect to do it just in the last year. So I suppose we're working very closely with government on that. We're trying to do what you're suggesting, Maynard, which is to try to balance that financial improvement at a rate which we can manage through our organisational capacity that doesn't really affect quality and safety and experience of our public or staff experience or performance in a detrimental way. But that's difficult for us as we're here in the finance paper. And I think you're right, Maynard, that some of the areas where it's almost easier to technically not spend money are in some of the corporate services, which are the very services that are helping our operational teams make progress and helping us meet our strategic aims or improve staff experience. So it is a really challenging balance. I think, when you look at the work in the next paper around the financial plan and some of the prioritisation and choices we're having to make, we put a lot of emphasis on our quality impact assessment to think through as carefully as we can the impact of any of those sort of shorter term measures. And I know through Quality and Safety Committee we want to make sure that we're keeping a close eye on that as well.
I mean, fundamentally we just need to be so vigilant around the way in which we are trying to reduce our cost base, at the same time ensure that we're still delivering services that meet the needs of patients and are of the highest quality and safe and of best value in terms of what we're trying to deliver. And holding on to all of those strands is a demanding, complex thing. But that's our responsibility as a board, as a unitary board. I'm not going to, I think we'll be discussing some of these items as we progress through some of the other papers, so I'm not going to suggest that we consider this any further. So just in terms of the recommendations, obviously received the update for the 25-26 annual plan. Lee, convey our thanks to the team who are responsible for both the hygiene around the annual plan, but also ensuring that we're working to delivering that. I know that comes through all parts of the organisation. Consider the additional financial and performance expectations since the annual plan was submitted, which I think we've done, and agreed that moving towards an aligned, triangulated process that will allow us to just view these things together as opposed to in sequence would be a really, really helpful thing for us to do in the future. So thank you very much for that. Let us move to our next item, which is the financial report. Hugh, welcome back.
Excuse me.
That's your music, isn't it? Just to say, welcome back. Fantastic to see you. We've missed you enormously, and I'm going to hand over to you.
Thank you, Chair, and thanks for the welcome. I hope the welcome will be shared after I finish this. Just I guess I'll reflect a little bit on the conversation we've just had around our plan. And if I start with, firstly, I think Audit Wales have just released this morning their summary position of health boards across Wales for last year. And of course, every health board had its statutory duty, failed on their statutory duty last year. I think that's an important piece of context for us. Health boards across Wales are struggling with a financial position, and that is replicated across the UK. Wales is no different to the challenges being faced across the rest of the UK. The challenge is an absolute one and a relative one. And the relative position for us, I think, can be addressed through our 3-year plan and our financial recovery roadmap. We are in dialogue with Welsh Government. And the clear response from Welsh Government is that we need to own our trajectory ourselves. And I think that's a very fair reflection of the position we've been in. We've been in this annual cycle for too long. The challenge for us going into next year is going to be one of a year of two halves, to coin a phrase, because we will be, Cabinet Secretary for Finance has already been clear that next year's position from a budgeting perspective at this point in time under this government is a rollover budget. So that's going to be a challenging position for us because we can expect no more than we currently have. So our current funding envelope will be maintained until after the election period, and then post-May will be in a new government, and it's for that new government to then decide what will happen in the rest of the year. That puts a really challenging context, I think, into our planning framework for next year, and one that will need to have a good dialogue with government on a handling strategy. If I just pick off then this year's position, and I want to thank the teams who've been working in my absence on the paper 9.1, which outlines a schedule of improvements that have been discussed in committee, in Finance and Performance Committee, and is coming here for public consumption. Welsh Government have been really clear that we need to get to a position of 24.1 million for this year, which represents last year's outturn position for us. Where we are at this point in time, I think we have relative assurance that we could get to 27.8, 28 million. That's the broad position I think we're in at this stage, and that's a recommendation for board to accept today, and 9.1, paper 9.1 will support us in achieving that position. We need to respond to Welsh Government by the 13th of October to provide assurance that we can get to that position. To get to 24 million, sorry, we're not in that position at this stage, and we are working on the further assurances that we would need to be able to indicate to government that we could get there. One point of note is that in our plan, the savings requirement we shared with our CCGs and our directorates, corporate directorates, in its entirety would get us to 24.1, probably through serendipity as much as anything else. The numbers just happen to coincide. But if the whole organisation delivered the original ask in terms of savings, we would get there. The challenge is that we haven't been able to achieve that, so we are in this position of needing these additional recovery actions. We're working with colleagues to see how we can address that. If we do get to 24 million over the next few weeks, there is a very material risk for us to consider, but I want to consider that almost separately from achieving that position, which is within our gift. And that separate risk is around the Welsh Risk Pool, and that's a material risk for us. For us, so the Welsh Risk Pool addresses our clinical negligence challenges, addresses personal injury claims that are made against the Health Board. In common with the rest of Wales, we are seeing a very significant increase in the rate at which claims are being settled. And that's a good thing for claimants, but has a knock-on impact on the impact that will have on us. Potentially at this point in time, there is a risk of between 4 to 5 million for us. And that's something that I'll be working with colleagues across Wales on addressing. How do we recognise that? At what point does that move from being a risk to being something that we need to recognise in our position? And if that is a point of recognition, what mitigations can we put directly to support the Welsh Risk Pool, and what mitigations do we need to reflect on within health boards? So that's just a summary of some of the risks and challenges that we'll be facing, Chair, and happy to discuss.
Thank you, Hugh. So obviously we've got a second paper, as you've indicated, 9.1, which will look at the financial choices and decision impact. So let's try and not allow these to bleed into each other. Let's just look at this in terms of the 27.8 at the current time. Rodri.
Just on that Welsh Risk Pool, would that fall into this financial year? And if so, should it be in the recommendations? Because I can't see it in the recommendations. I know we're looking at it apart, but just wanted to, looking at the recommendations, there isn't anything there regarding the Welsh Risk Pool. I know there's more discussions to be had, but just to have that clarity.
Yeah, Chair, at this point in time, it's a risk.
It hasn't materialised.
And it hasn't yet materialised. I'm working with colleagues. We'll be having a conversation tomorrow, actually, as a finance community on at what point do we take the recognition point of that, and that comes into our forecast and our position. At this point in time, I would envisage something crystallising this year, but at this point, we haven't got that in our position. It is still a risk until we've recognised. I'll bring something back to the next board meeting with more detail on that.
So it doesn't need to be recognised in the recommendations.
At this point,
At this
no.
point, fine.
At this point. And we need to be mindful of it, but it's not there. Good point, Rodri. Chantal?
Thank you, Chair. I just wanted to ask a question in relation to the fact that we've not been able to make this, some of the savings, and we're having conversations with the various groups in order to ascertain how we might make it more robust in order for us to be able to achieve that. So do we at this stage know the reasons why we haven't achieved that? And what exactly are we going to do in order to make the plan more robust in terms of the savings delivery?
Yeah, thank you, Chantal. And this probably merges with the escalation conversation that we may have shortly. But there will be reasons across the organisation. But if I just pick on, I guess, community and integrated medicine as an indication, okay? So we know that the CCG is dealing with the changes that need to be made in urgent emergency care. I would very much hope that as those changes are realised, as we address clinical variation, as we address challenges in flow, there will be a financial benefit coming out of that, because there's a huge amount of financial waste that we are incurring at this point in time because of the challenges in variation and delays in flow. That's one example of the changes that I think need to be put in place to address the core drivers of our financial position, not just, put a sticking plaster over the financial position itself.
Okay, thank you very much.
Good point. I mean, for me, there's something about the fact, because if you look at where we've not managed to deliver or are not managing to deliver those cost savings, quite a lot lie in that community and integrated health space. And it does feel to me, when I think about the challenges there, they are systemic ones. They don't just sit in one budget. They are much more broader than that. So, and when hopefully, if we can address some of our challenges around urgent and emergency care, we will see an impact of that in terms of, and it may be that at one stage those costs will increase as we try to grip this as a long-term solution, but in the short term we've got to recognise that's where some of the breaches are in terms of savings around this at the moment. I'm going to suggest we move through this. We'll just look at the recommendations now, and we'll move on to the next paper, which I think is important for us to consider. So, first of all, approve the revised forecast deficit at 27.8. So, do I have the board's support in approving that? Great. I think we've sought assurance on progress of savings actions from the executive portfolios. I think that's come through as well, and also that sufficiently robust plans are in place to eliminate the use of healthcare support work agency staff. Lisa, I'm looking at you. I'm presuming we do have those plans in place.
We do.
Great, okay. And note that a proposal for options around future run rate conversion has been discussed by exec team. And the option to recognise 11 amber schemes centrally referenced against each portfolio with the risk-adjusted extrapolation values totalling 6 million has been included within month 5 position. And acknowledge that an underlying deficit assessment has been undertaken and identified, and this will only be reduced by robust recurrent savings delivery improvements. I think that's where our risk lies. Fundamentally, it's those recurrent savings. Okay, great. With your support, I'm going to move us on to our next item, 9.1. And 9.1 is largely going to take us to the Financial Choices and Decisions report for 25-26. Bill?
Yeah, look, I'm happy. I'm sure Hugh will want to come in on this as well. So I suppose as we've led into this, we made a plan to get to 31.5 million. We've been asked to get to 24.1 million. When we set our plan in at the start of the year, we set a plan that we felt was balanced between quality, safety, experience, performance, finance, safeguarding the future, and looking after our staff. We did our best, I think, balance what we felt was quite a challenging plan at the start of the year. As I said earlier, it's not surprising that Welsh Government would expect us to get back to our out-term position, given in previous correspondence they've asked us to get back to a balanced position. In fact, I would say that is absolutely our aim. In fact, it is our statutory duty to get to a balanced position, and we've always sought a route to do that. So actually, our original plan didn't start to tackle that. So we've, as we've seen in the previous paper, we took actions to get to 27.8 million. What this paper starts to describe, following it describes the process we've taken to look at options to get back to 24.1 million. In fact, there are opportunities from a financial perspective to get us back much further than 24.1 million. We've categorised those options into category 1, which we've discussed previously through our board seminar. Which we felt were the ones that were easiest to harness. You'll see that category 2, which we've discussed previously, are the ones which we felt were more difficult, but we felt we should look at. And category 3 were areas that we felt were probably we should not be trying to harness because of the risks to it. When we've looked at all the quality impact assessments for every single one of those potential programmes of work, they all have some sort of adverse consequence, whether it be risk to the quality of care that we provide, risk to performance, risk to staff experience, the future. They all have some sort of risk, and I suppose that's not surprising to us, because the plan, if they didn't have a risk to them, then they would have been in the plan at the start of the year. So this gives us a real challenge around prioritisation, I suppose. What you'll see also in the letter, the correspondence between myself and the Director General, and that following our board seminar, in committee board discussions, that I did have then a meeting with the Director General and the Finance Director in Welsh Government around the actions we'd taken to get back to the 27.8 million. What this paper starts to describe is also the options to go further back to the 24.1 million. You'll see in the final letter from the Director General that the expectation that that by the 13th of October that we write back to them with a confirmed route back to 24.1 million and with full green savings. I have to say, in the discussion I had with government, I did explain how difficult that would be, the challenge that would be, particularly the element of achieving full green savings across the board. I explained that would be a significant challenge, and something that is unprecedented for us, because and indeed possibly any health board to be able to achieve that at this point in the year. I think the positive thing I would say is we're only we're only at month 6, so we're only part of the way through the year. We've got a significant amount of the year to go. So I think we've got we need to approach this professionally. We are at the moment, as an executive team, we have put in a process to assess those category 2 areas in more detail, look at what controls we might need to put in, and we're re-looking at the quality impact assessments for those category 2 areas. But I don't know, Hugh, we might want to bring in Hugh.
Hugh.
Yeah, thank you. And I won't repeat anything that Phil has said. I guess I'd just reflect that the genesis of these were because these are the areas of variable costs we incur as a health board. And the reality for us would be that this is probably the go-to area that we would come back to year in, year out in terms of addressing things in a transactional way. I think there's a challenge for us that addressing and mitigating the quality impact may be different in the short term. So some of these we may reject in the short term because we can't address the quality impact, but they may be things that we can come back to as part of future planning where we can have other mitigating actions to address the quality impact that we would see. So even if we end up in a position where some of these are discounted for this year, I do see us coming back to some of these for future years where we can, in a more planned way, address the impact that we would foresee. Obviously, a degree of these have already made them into now the improvement that we've already approved then in getting to 27.8. The challenge for us is, can we go further, and can we then see an improvement from that 27.8? Thank you.
Okay, colleagues. I'm not proposing we have a conversation about what's in or what's out in this list. It's a broader conversation about the principles of what we're trying to deliver here as a board and how we endorse the executive and the organisation continuing to work towards reducing its cost base. Because fundamentally, that's what we're on about. I think Phil, you provided the rationale for this is we need to be operating in a sustainable way. We have to operate in a sustainable way. When I joined the Health Board last year, my first mission was we must become sustainable, and that means living within a cost envelope that we're given by Welsh Government. So the rationale behind this is a solid one, it's a positive one. The challenge for us is to really continue to make that shift towards deepening those cost reductions that we're trying to exercise within the organisation. I've said it before at these board meetings. One of my concerns is that we need to be able to transition from cutting our cloth, which is really about snipping the edges of what we're trying to do, and to fundamentally rethink some of the service paradigms around how we deliver our services, where and when and how. And also thinking about our future investment in alternative technologies that will have an enormous impact upon how we think about our expenditure. So it's really important for us not to just focus singularly on how we cut our cloth or how we just snip the edges of our current expenditure, but we think more broadly about how do we transition to a cost base which is much more sustainable because it involves a lot of service reconfiguration or transformation and improved value in terms of what we're trying to deliver. And I think we're on that journey, to be honest. I think we're on that journey. Hugh, and then I'm going to come to Anna.
Chair, just reflecting on the point that you've made there about the journey we've been on from when you started as chair, and at that point we were a relative outlier in the rest of Wales in terms of our financial position. So I keep coming back to there's a relative challenge for us and an absolute challenge for us. We have largely addressed the relative challenge of our position against the rest of Wales. We're now in the pack, as it were. The challenge for us now is a absolute challenge of improving on our bottom line to get to a point of sustainability. And I come back to the point that Welsh Government made around we need to own our improvement trajectory.
Indeed. Well made. Anna.
Thanks, Chair, and wholly support the comments that both you and Hugh have just made. I think therein lies the tension, really, the decisions we make for the short term versus the longer term, and I think that has been a key part of the wrestling that the board has been through in various different settings. I just wanted to make a comment because I think if Michael were not stuck in traffic, he might be saying this as chair of the Finance and Performance Committee. We did convene an extraordinary meeting of that committee to consider the line-by-line detail. So while the board is not going through that today, that has been undertaken against the Category 1 schemes, and in fact some adjustments were made as a consequence of that dialogue that happened between the executives and the independent members, first through the board seminar and then in that extraordinary meeting. So that scrutiny has taken place in support of the board's discussion today, and I think the committee's expectation would be that as we move to category 2 scrutiny, similarly the committee would expect to have that level of granularity to provide full assurance to the board when the time comes.
Thank you, because I think we rely upon scrutiny within that period, working through each of these recommendations. Eleanor.
2 brief points. I think one of the other challenges which will be picked up later is in the productivity of the organisation. One of the challenges that will be picked up later is the productivity of the organisation, and that is a key element of getting towards where we need to be financially. And the other bit of context I want to recognise, we've got a paper later on the social model of healthcare. We talk about prevention. All these future things are really important. We are delivering the now, delivering the savings, but actually shaping an organisation fit for the future. And therein is one of those tensions about what we do now without taking into account Neil's design principles at the start, preventing us doing something that stops us being an organisation which is not only financially fit for the future, but serves our communities and our population in a better way and a healthier way.
Completely, Eleanor, completely. That's the space we need to get into. I'm going to, you, and I'm going to come to you, and then I'm going to, Aldiana, if you want to say something, and then I'm going to close the item and we'll go to the recommendations.
Diolch, Cadeirydd. Thank you, Chair. Again, just want to kind of recognise the work of finance colleagues, particularly working across the whole organisation in terms of addressing, the challenges here. But I think perhaps is there an issue that perhaps we're only looking within our sector in terms of how we can learn to realise savings. I've been party recently to discussions with police forces across Wales in terms of how they're using AI in terms of supporting victims of crime. And they are increasingly being challenged in terms of looking to realise savings across all police forces in Wales. And whilst their budgets are relatively smaller in terms of compared to what we're looking at, the relativity in terms of percentage savings that they're being challenged to actually address and deliver by the Home Office in this instance is a similar scenario to what we're facing with Welsh Government. And I think it may be worth perhaps, rather than putting pressure on ourselves all the time in terms of within the organisation and across the health sector in Wales, to look at some of our other blue light services across Wales. And certainly, whilst not perfect, police forces in Wales are certainly demonstrating that the use of AI and technology to realise a quicker response to victims in this instance, to work with communities, as the Vice Chair was saying, in a more kind of timely response, has realised cashable savings, which they're now able to demonstrate year on year. And they have been able, in terms of one of the forces I've spoken to recently, identify further savings above and beyond the targets they've been set by the Home Office. So I think it may be worth perhaps that we have a conversation to realise how technology can support our clients and patients as it is supporting victims across Wales in terms of with the police forces.
Very good point. I think we have, I think sometimes we presume we have to solve our own problems, and indeed we do, but the expertise and knowledge that we can draw upon to help us do that can come from wider afield beyond the parameters of the health service. So I think you're absolutely right. I suspect, I'm looking at you, we're probably in that space already in some regard.
Yeah, Chair, thank you. I think Eleanor's point and Ewan's point provide us with some principles that we might pick up as part of planning for next year, financial planning certainly for next year. Yeah, we are. There's always more you can do in that space of looking out and looking up, but that's a point to certainly support that principle. Obviously, our partnership with CGI now gives us access globally to what's happening, and that probably gives us access to different sectors as well. So I will pick that up specifically and bring something back.
Thank you very much. Yes, please, Aldiana.
Excuse me. Thank you, Eleanor, for the points. I think that's a permanent and not just the health boards tension between investing today for the future and spending today's money for caring for those immediate needs. But we also know, and we heard again and again yesterday at an executive team from presentation from our lead consultant for emergency services, that majority of the patients that seek our health care could be provided with those to meet those needs in a different way and elsewhere. So we've got that evidence that most of the patients that are today in most of our emergency departments do not have needs for emergency medicine services. So that is the tension that and the decisions that we have to make, that today is the right time to actually shift the resource and to invest in more preventative and the more prudent care and help to the communities that we can provide. And we've got, yes, social model for health. You'll see in the paper later on in the Centre for Social Innovation that we are learning from elsewhere, and we're seeking to embed in the annual planning and further on the community health and well-being workers within the social model for health. We had the executive decision earlier for this financial year to invest in expanding a health coaching model which combines the digital, the prevention in health settings, and we have agreed again principles as Hugh just referred to last week as an executive team to frame better those shifts for the next annual planning as well as the long-term strategy. That we make those choices to spend more prudent way money to secure our future better. Thank you.
Diolch. Thank you, Ariana. So just to pull the item to a close. First and foremost, I think I'd like to thank Andrew Spratt and Sean Jenkins, who valiantly and heroically stood up in your place, Hugh, when you were away, and did a sterling job during quite a difficult period. So they did a great job and gave us great confidence in you and your team in terms of how you're operating. So what's emerging from this conversation for me is the realisation that if we deliver our cost savings by the end of this year, we broadly, over the last 2 years, would have saved in the regions of around £90 million inside this health board. A considerable sum of money. And a lot of that would have been saved through efficiency planning, through cost reduction, through ensuring that we are focusing upon reducing our waste, achieving better value out of the services that we're delivering and we purchase. So we would have used and employed a whole series of skills and valuable insights to deliver that outcome. And we are yet to reach that stage, but it will be a momentous point when we've kind of got to the end of that and we've delivered significant sums of money. But I do think there's a point at which we start to think more broadly about our financial strategy as we move forward, that it isn't just contingent upon cost savings. It will be contingent upon everything you've just said, Ariana, thinking about a different model of healthcare, thinking about the social model of healthcare, thinking about how we address issues of productivity, thinking about how we embrace new technologies, new digital technologies, but also conventional technologies, hard technologies, how we redesign the configuration of our service delivery, all of which is embedded in our clinical services plan at the moment. So for me, the next stage is a shift when we start to do that kind of financial planning away from the kind of conventional stuff that we've been engaged in. It's been valiant, and I know that work is already underway because we've had those conversations already, Hugh. But that's where our focus needs to be in the future. So coming back to the board to note, well, obviously we note the current expectation that we must reach an outturn deficit of 24.1 by the end of the financial year, and I think we've had some discussions, and through the Finance and Performance Committee, we have an assurance that there's a scrutiny taking place in terms of where we can engage in further cost saving, but balance that against the importance of not increasing our risks, not exposing us to safety or quality issues in the process, and we will need to continue to pursue that, and also to recognise that we are heading towards hopefully a 27.8%, 27.8 million deficit, we need to reduce that by a further 3.8 before we get down to our 24.1. And obviously we will need to, as we did, ratify it in the in committee on the 9th of September 2025. Hugh.
Yeah, Chair, just to provide the board with assurance, and with your permission, I'll take an action out of the board to take something back into F&P as an extra agenda item, which provides us with a crisp summary of how we would get from 27.8 to 24, and then we'll bring that then back to the next board as part of hopefully resetting our position again.
That would be very helpful. Thank you very much.
It's likely that I will need to write to, we will need to provide the information to government on the 13th. Well, we will need to provide that information on October the 13th, but it might be in advance of our board meeting. So we will make it clear, if we haven't had a further board meeting before that, that it's subject to ratification by our board.
Great, okay. Thank you, Phil. Let's close the item and let's move to Integrated Performance Assurance Report. Hugh, we're back to you.
Thank you, Chair. I'll just highlight some of the headlines of the position and naturally focus on areas of concern for us. Clearly, the position in the IPAR on urgent emergency care has changed significantly since the report was written, and we've already talked about that, but naturally the position in the IPAR is based on August, and that wasn't an acceptable position for us to be in, and we've heard already about the work that's been done since then, so I won't go into that in any more detail at this point. I did want to highlight a few areas of concern, particularly our position in therapies, where we have got the highest number of breaches we've ever reported in terms of patients waiting more than 14 weeks. That's naturally a point of concern. Podiatry, dietetics and physiotherapy are running as particular challenges for us. Psychological therapies is also an area of concern for us. Our position did improve in last year following the introduction of group therapy sessions, but then it's declined for us now for the 9th consecutive month, so another area of concern. Our position on high-risk eye care patients is also well below the 95% target, but we have started to see improvements in recent months, and we've got to 69% in July. Continuing now to work with colleagues regionally in Swansea Bay as part of that improvement work. But I am pleased to note our position on cancer, in particular where our position has been maintained above 60%. We achieved 62.3% in July. If I move into escalation, because I think there have been some questions that have kind of alluded to our escalation position already. There were a couple of issues I wanted to flag. Our two most challenged clinical care groups at this point in time would be community and integrated medicine and planned and specialist care. Those are the areas with the highest number of escalation areas, and I'm sure we'll get into discussion around that. We've heard about the improvement work in community integrated medicine, and naturally there's an awful lot of work in planned and specialist care on improving our waiting times and addressing theatre capacity challenges and critical care challenges. So there is work ongoing there, but they are areas of natural concern. And there is an ongoing challenge, and we're reflecting on this as an executive team in terms of the number of areas that are escalated and the continued stickiness of that escalation for us, I guess would be the best phrase I can come up with now, and how we address that as part of our work over the autumn and as part of our planning process going into next year.
Thank you, Hugh. Colleagues, questions?
Thank you very much, Hugh. I'm looking for more reassurance. One of the papers you've identified that our sickness rates have increased under workforce, and it's gone more long-term sickness rather than short-term sickness. Are we investigating the reasoning behind this? Is there anything we can put in place to support long-term sickness or in any way? And the second question is in the other part of the paper, and it's to do with facilities, because we're not reaching our national targets, we're not reaching our audit targets. And I know there's a new organisational structure. Will that be their focus in the first few months of when they get in place?
Thank you.
Thank you, Anne. Let's see if there's a few other questions anybody would want to take, and then we'll come back to those. I think Hugh will probably be fielding those. Eleanor, yeah.
Mine is a small point on this. It remains a stubborn number. It's the number of C. diff cases. In August, we projected 8, it went to 10. It doesn't seem to come down ever. Is there a reason for it?
Great. Let's hang on to that one. Maynard, and then we're going to come to Anna.
Yeah, mine's a more general point in the table on page 291 of the pack.
Maynard, pull the microphone to you.
Thank you. Apologies. Yeah, it's the number of high and extreme risks. The highest we've ever had is 491. We're now at 489, which is an awful lot of high and extreme level risks. And does that indicate a fragility in the system that we're in danger at some point of those risks becoming reality?
Very helpful. Okay. Anna.
Thanks, Chair. I suppose mine's a sort of general question around the measurement methodology that we've got. I'm sort of wondering, when I look at this data, I'm struck by how many 3s are just kind of stuck at 3 and have been month after month after month. And I'm struggling to understand whether the board should be tolerant of that or whether we should be starting to ask questions about why are we not shifting on these. Yeah. Is it because the methodology is not sensitive enough to reflect the steady progress? Is it because there are some aspects that are simply beyond our short-term control to do anything about? Perhaps some of the workforce metrics, for example, or some that are connected with estates and capital investment. But what about those things where actually we should expect movement? For example, around outstanding complaints, outstanding actions from regulatory inspections and so on. I just would like to hear some exact comment about how long should the board tolerate a flatlining 3 before it starts to up the pressure on a different course of action.
Okay, great. There's a hefty number of questions there. Hugh, I'm going to ask you to address those and field them as you think appropriate.
Thank you. Just to warn colleagues then, I'm sure Lisa will come to you on sickness, I'm sure James will come to you on facilities, and Sharon, I'm sure I'll come to you on C. diff. So if I just start off with the number of risks, and Joe, I may bring you in at here as well. Number of high and extreme risk, I think we are seeing a growth of them, and you're right, this does represent a challenge in the underlying issues we're facing as an organisation. And I think some of the challenge does link back to our financial challenges as well. And we're not in a position to invest in order to de-risk some of those issues. So if we're to be fully reflective of the investment that needs to be made to address our core underlying issues, then there may well be a further financial challenge for us to reflect on. That's something we do need to pick up. But there's also something here around, we've got now new operational teams that are maturing, that are developing, that are understanding the landscape more, coming in with a different perspective and identifying areas of risk that perhaps just by having been in the system for longer, older teams it was becoming normalised. So I think there may be just a new perspective that is identifying those risks. But we do need to pick up the level of risk that we're carrying as part of next year's plan, and I know Lee has already got a piece of work in place to try and understand how we bring that into our planning framework. Measurement methodology, if I pick that up, Anna, it's a source of concern for me too. I think this is less around measurement sensitivity, because our sensitivity is around a level of understand or level of assurance, and we've got 3 levels of assurance that we're accepting here: reasonable assurance at level 1, limited assurance at level 2, and then no assurance at level 3. So we've got no assurance that we will improve on our position in these spaces. It's probably less around the sensitivity of that, although I take that challenge and will reflect on it, and more around how we address those. I've split the escalation framework, often kind of certainly in my own mind, between the quality governance and workforce metrics that we're tracking against that are largely input metrics. They are largely management actions that could address them in terms of the way in which we track those escalation measures. There may well be underlying reasons for the level of actions that need to be tracked that are probably more systemic. But in terms of the actions that need to be taken to de-risk or de-escalate, I'd say they're more management actions. And the finance strategy and performance issues that are more leadership, systemic, challenging positions for us to be reflective of. So I think we've got a lower, I think implicitly we have a lower tolerance level for some of the management actions that need to be taken to address those first 3 areas of escalation. We are getting into a place where the continued position of being in level 3 is raising further conversations for us as an executive, and we need to, over the autumn, address whether we push into a level 4 escalation area or whether we address these through a planning framework going into next year. We've already heard about some of the work that's being done that's more systemic within community and integrated medicine. Some of that work needs to reach its fruition, and we're not going to address this until it's had time to mature and address the core underlying causes. But your challenge is well made, and one that we are, I think, need to be continually reminded of. And then I think
the critical question was, how tolerant should we be of this? You haven't answered that, Hugh. But we'll
I think that is a very valid question that we need to come back to, I think, in a more measured way. I don't want to give a response now that doesn't provide the right level.
But then you leave a vacuum for other people to respond to that question.
But I think we do need to bring it back into a board seminar conversation, actually. That is probably a discussion around our tolerance.
That's a very good idea. So let's go back to that question about our toleration level as a board and deal with that in a board seminar where we can have a free and open exchange of views and discuss it more broadly and more deeply. Very good. Okay, so I think we were going to come to James and to Lisa.
Diolch for the question, Anne. I think in terms of workforce and particular around facilities, what we've seen is that we've got investment in, or should say movement and allocation of resources differently within the Facilities Directorate, which has allowed us to put more effective measures in place to monitor and track how we're supporting staff who are off sick, short and long term. I think in addition to that, we've recently had the recruitment for some new roles in terms of facilities managers that will support our more local teams at more local level, where we've got that more local ownership. So that feels like a really important step in the right direction that's sustainable to some of the challenges that we've been experiencing. That recruitment has taken place last week, this week, and I'm looking forward to giving an update at the next seminar. Thank you.
Thank you, James. Lisa.
Thank you. So in terms of sickness absence, we've got 2 pieces of work that we're looking at in terms of long-term absence. So one is we're working with our trade union colleagues around how can we support individuals to return to an alternative role if they can't return to their substantive role with occupational health support. So there are some people who could be on a waiting list as per our general population who want to be in work but can't undertake their role. So that piece of work will help us enable people to return to work. The second then is we've started, and it's very early, a piece of work with our public health team around our population health, and we've been mapping our workforce and where they live to the demographics of the local population, and where we see healthy life expectancy. So in some of our populations, healthy life expectancy for a woman is 57, and we have a number of individuals within our workforce who are over 57, and therefore the reasons for absence are replicating what we see in the population. So the work that we're then looking at is, so what does that mean for our occupational health and staff psychological wellbeing service, and can we change that and adapt it to meet the different needs of the different populations? So it's very early days, but I think it's a really good piece of work that we are doing to support our staff to remain healthy in the workplace. Can I just pick up as well on the point that Anna asked about tolerance? So we've been reviewing that from a workforce point of view, and in the workforce domain we've got turnover, sickness absence, pay progression, mandatory training and PDRs. And I think we've got two separate streams of work there. So one around sickness absence and turnover is a rolling percentage, and therefore it could take several months before management actions will change that result. So some of the things that we look for in there are return to work interviews are done, because that is actually something that people can enact. And the other things then around, we're looking at, the things around tolerance, is we would not tolerate that staff don't get a performance review to enable pay progression. That should just be something that happens. So we're trying to separate the two so that we know which ones we have to tolerate and which ones we shouldn't tolerate. But that's helpful.
Thank you, Lisa. Sharon.
Lovely. Thank you, Chair, and thank you, Eleanor, for the question. If I pick up the CDIF query, and you're right, it's multifaceted, and the goal is below 10, and we had 10 in the last report, and those are hospital onset C. diff infections. So across our 4 laboratories, we are aiming for less than 8 infections per month. So I guess the August report reflects in part some norovirus outbreaks that we had during the summer, and when you have those outbreaks, we increase samples going into the lab, and therefore individuals who might carry the organism asymptomatically, we detect it because they've got symptoms because of the norovirus. So if you seek, you will find, and we do have a low threshold for sampling, which is the right thing to do from a patient safety perspective. I think the other issue is around antimicrobial prescribing. We've got a lot of work going on in that space, and the Deputy Medical Director now chairs has oversight of that as well. So we have to focus on antimicrobial prescribing, and we're very much targeting certain antibiotics like tazocin and cotrimoxazole because they are high-risk antibiotics. The other thing that I've noticed, which is a risk factor for C. diff, is proton pump inhibitor prescribing. So your medication that will reduce acid secretion in the stomach, like lansoprazole, etc. And 67% of the patients who have C. diff are on those medications. So there is work that we need to do in that space as well. And notwithstanding the environmental factors, and as James, that work will obviously contribute to the overall strategy for reducing HCAIs. Yeah, so the important thing is that we've got a lot of scrutiny in this space, and we need to make sure that we keep on providing assurance in those cases as well.
Great. I'm going to close the item, but not before saying that I think one of the challenges around the escalation report is that I think, Anna, you've identified it, and others have as well, is about the kind of stickiness of some parts of our services that are being delivered that constantly hover in that third kind of space, that kind of that third tier, and it is really challenging in the sense that one would imagine that where there's no assurance associated with those services, that frankly there's no management. That there's no management of those services, because I would have thought the fundamental purpose of managing those services is to manage them well. Now, I'm not for a moment thinking there aren't a whole series of reasons why, contingent reasons why it's possible to still be managing a service and for it not to deliver well. But there is a fundamental contradiction there. If these services are being managed and delivered well, having a state where there are no assurance associated with their improvement is not really acceptable. It's not really acceptable inside this health board. And it contrasts with those parts of the service that are delivering exceptionally well and are maintaining the standard. So it is an agenda. There's an urgency around us needing to tackle this, and I think we can address the question of our tolerance as a board to recognising this kind of suboptimal performance, frankly, inside the organisation. But the reality is, regardless of whether we're tolerant or not, this needs to be dealt with inside the organisation at a management level. This is a performance issue at a management level. Yes.
So, yeah, so I agree. I do think we need a board seminar discussion. I mean, it's really complex because when you look at our performance report, you know, and some of the recent improvements in ambulance handover, which isn't just the ambulance handover, it's like the whole system improvement, that has taken place through the hard work and really great oversight and management and clinical leadership in Community and Integrated Medicine Directorate. And the other area which you mentioned around plan care, we're on track, I think, to deliver our planned care targets, and indeed our cancer performance has stayed steady. We recently de-escalated, and we've got plans to improve that over the next year. And in addition, you know, we're making improvements in our financial management, which other health boards have struggled to do. So when you look at all of those areas, that's quite significant, and that doesn't just happen by chance. That happens with really strong operational management oversight and clinical leadership. It couldn't happen otherwise. And yet, on the other hand, you know, there are all sorts of examples where we haven't got the patient experience right, and we haven't got the financial management right. So there is, I suppose, going back to Anna's sort of question, how do we consider that effectively and then come up with a view of a category 3 for those directorates, and the words sort of no assurance and then by implication no management oversight sounds rather stark, given actually it's more nuanced than that, because there are all sorts of things where we are delivering and improving. So I think it's something I know we're reflecting on as a team, and we do need that board seminar discussion. There is an issue at the moment, frankly, that we are having to be on the financial challenge, as we've described earlier. We are having to take some quite short-term decisions, and a lot of it is reducing our corporate capability to make progress. And I suppose therein lies the challenge. It's a challenge of sustainability, I think, for our the kind of services that our operational managers and clinical leads are trying to run, and some of it will require change for them to be able to operate in a much more effective way. So yeah, I suppose what I'm really saying is I do think we need that board seminar discussion because we don't really have the time in this forum to get into that level of detail.
No, you're right. And I would say there's not an implicit criticism here.
Yeah.
We think this is not being invigilated, because I think we absolutely see the executive colleagues kind of on the case, yeah, and doing their best to sort this out. But there's just something missing. There's a gap. And our role is to seek assurance and be assured, and we're not. And we're becoming tolerant of not being assured, yeah, in this space, and that's not acceptable as a board. Okay, with that, then I'm just going to say that we've agreeing with the recommendation that we've obviously fully discussed this and received assurance to a degree on the delivery of these improvements in this area, but we need a great deal more. And that board seminar will help, I think, for us to start to explore what kind of assurance we need in this space and how we can put that in place as soon as possible in the future. Thank you very much. I suggest we take a refreshment break at this point. Thank you, colleagues, for coming back so promptly. Can we now move to our next item on the agenda, which is management of waiting list, DNAs and appointments. I think Andrew was originally here to present on this. Gareth, I'm presuming you'll present in this place.
Yeah. Thank you, Chair. And first of all, I'd like to say I've probably reflected on the content of the paper and
Gareth, sorry, can you just pull your microphone nearer? Thank you.
apologies.
Yeah, thank you.
So thank you, Chair. First of all, I think I'd like to say I've reflected on the content of the paper, and I think it's a bit one-dimensional, shall we say, a bit too process-orientated, and I've reflected on the fact that what the paper doesn't say is what should we be doing for our patients, and how should we be addressing some of the concerns that they've raised through various forums around how we communicate with our patients, the content of that communication, the accuracy of the communication, and the timeliness of the communication, as well as other factors. So the paper tries to explain the parameters in which we have to work as a health board when it comes down to Welsh Government expectations in how we manage our referral to treatment waiting times. Having had various conversation and in various forum over the last couple of weeks within the health board, particularly at exec team, where Sharon shared another paper on the broad subject of waiting list management. I think it's fair to say that there's quite a considerable piece of work that needs to be undertaken in this space. And I think, having had discussions with various exec colleagues, there's a willingness and a desire and a commitment to undertake that piece of work. And I think the output of that work could be fed through QZEC as a suggestion, because I think we're recognising that our communication isn't what it should be. We can do better. And without trying to preempt the outcome of that piece of work, I think within our current infrastructure, we've got the ability to do better. I think it needs a sort of deep review of our current systems, our current practices, and a redefining of how we provide the necessary support to patients going forward. So I wanted to sort of make that point first. Now, whether or not I should pause there and take any questions, because
I would pause there if I was you.
Yeah.
Thank you, Gareth. That's a helpful admission in terms of the paper, which I think we felt hadn't quite... The rationale behind asking the paper to come to the board was our concern over individuals receiving correspondence from the health board that was often very late or not well expressed, and which often resulted in those non-attendances as a consequence. So I suppose what we were searching for in our paper was an explanation that would help us understand that, and the paper didn't address that. It provided, as you quite rightly described, it provided an overview of the process that's undertaken in that. And at the very least, what we got was an overview of an enormously complex process that doesn't seem to have any systematized central intelligence or management around how this function is delivered, and certainly isn't embracing, technology as we understand it, or AI opportunities in the future. So that's really where I think we probably came from in terms of that. I'm not holding you responsible for that. I know where these papers are often generated. I'm going to ask for colleagues to offer their views or thoughts. Eleanor, and then Sarah, and then Anne, and then Ewan.
Diolch Cadeirydd, and diolch Gareth. Thank you very much for your presentation. Thank you very much for your presentation. You've answered a number of the questions I was going to ask because it was just a list of the process. I'd really welcome seeing the more in-depth version that you talked about to understand what's going on more, because my understanding is bits of it go centrally, bits of it go from consultants, PAs, some things go out from an appointment saying it's not random, that's the wrong word, but there are many different ways people get told. And the thing that I really want to push for is when we have to cancel appointments, which happens, it's not just about giving somebody an explanation, but thinking about it from the patient's perspective or the family's perspective, another appointment at the same time as we cancel, because that's the bit that often causes people worry and concern, is how long am I going to have to wait for the follow-up appointment. So I just welcome knowing more about what's going on at the appropriate time and what we're doing.
Before
so
you come back, Gareth, we'll take some more questions. But I think that's a really important to make. Thank you, Eleanor. Sarah.
Diolch. So from the paper, one of the things that concerned me was the fact that we're sending about 19% of our letters out that don't constitute a reasonable offer of an appointment, so they're less than 10 days' notice, which seems to me to be a bit of an invitation to DNA. And with DNA costing us probably something in the region of £30 to £50 per missed appointment, that feels like a big hit that we could be managing. And if I may, I'd just like to offer an example of the impact of this. So this happened to a friend of mine in the last few weeks. She's given me permission to share this. So she received an appointment letter from us offering her an appointment in 6 days' time. She phoned up repeatedly to try and rearrange that appointment because it wasn't convenient. Finally got through to somebody and was told, no, it's fine, it's a telephone appointment. We'll phone you. Okay, that's fine. She's dealt with the board before, so phoned again just to check that that was a telephone appointment. Yes, you'll get a telephone appointment. So she sat there and waited for an hour and a half at the time she was told she would be phoned, and no phone call came. So she phoned back up and was told, oh, you didn't attend clinic. You've DNA'd. Absolute insanity. She was sat by her phone. She had been proactive and contacted us and still missed her appointment. To add insult to injury, and this is a slightly different issue, but it touches on the way that we communicate. That happened on the same day that she received a consultant letter about a procedure she had had. And I'll quote you the beginning of it. I'm pleased to say your recent procedure showed signs of cancer. There was one word missing from that sentence. But the impact of that was absolutely huge for her. So I just think there's something here about this is a real world problem that has those sorts of impacts on our patients, and I just want to kind of remind us of that when we're looking at something that's very procedurally based. There are impacts to not getting this stuff right.
Completely, absolutely completely. Okay, let's hold on to that as we explore other people's thoughts.
Thank you, Chair. Mine is similar. It's just that when you're doing your review and you're planning in the future, it's the same thing. I've had permission to inform patient was sent an appointment, orthopaedic outpatients, Aberystwyth, couldn't attend, rephoned, resent the appointment. Your appointment can be in Llanelli. Now she lives in Llanelli. So why couldn't the appointment have gone to Llanelli in the first place? Is there anything in the system that identifies postcodes to people that you're arranging appointments for instead of sending the other part of the country? And can that be taken into consideration in the future development and planning?
Thank you, Anne. Really important point. Hywel.
Diolch Cadeirydd. Again, I think, as independent board members, we're in a privileged position where members of the public will share their stories with us. And similar to both Anne and Sarah, I've had permission to share a recent experience elderly couple living in their 70s on the Pembrokeshire-Carmarthenshire border. The wife is going through a very aggressive kind of treatment for cancer. They requested a face-to-face meeting with a consultant to get reassurance on the next stage of treatment. And because of their postcode, they were offered a meeting in both Withybush and Glangwili. They opted for Glangwili because for them that was closer. And then they were sent a letter by saying, well, no, actually, you need to go to Withybush. So they went to Withybush on the date and time assigned. They were taken into a room to have a video link with a consultant in Glangwili when they were prepared very clearly and had articulated to go to Glangwili to have this face-to-face. Now, the couple were very grateful, and I think that's what we see within our general public. They are grateful for the interaction, the support of our clinicians and of our staff. The problem is in the administration, and this is the frustration across all of the organisation, I think, that we are seeing with our general public, is that they appreciate the pressure all our staff are under in all areas and all directorates, but the system is not working. And, you know, despite clarity in terms of, you know, where you'll be, what time, in what forum, etc., somehow the system is not recognising those requests to support who we are all here to serve, which is our public. We're not here to dictate to them, we will, you know, kind of do this because this is what we want. If they request face-to-face in a location, we need to make sure that we honour that and do it sufficiently and properly.
Thank you, Ewan. Rodri.
Well, I suppose from what Gareth has said, and as you say, from reflection, perhaps this paper doesn't give us what we need to know. And it does say in the paper that there will be an external assurance review led by NHS Wales, National Director for Planned Care Performance and Improvement. And the report is expected in December 25. So I'm just wondering, it will become to QSEC, it will become to ARAC.
So, Chair, just to explain that was a specific request from the Audit Committee in terms of RTT. Yeah. So it doesn't cover all the appointments, which is what Gareth's already said. That was in terms of how those particular appointments were managed. Yes, it will come back to Audit Committee because as yourself of Audit Committee and the Chair of Quality and Safety Committee have inputted into those terms of reference, it will need to come back through governance to highlight any learning that we need to take, because we do know there is absolute learning we need to take from the reports that have been to the previous audit committees.
And my suggestion is that the learning from what will be coming again, I think we need to have this paper back in board at a later time, perhaps after all this information has been compiled and everything put together. That would be my suggestion, because I'm not learning much from what I've got in front of me there.
I think, dwi'n cytuno. We agree. I agree. Joe, would you like to bring in Donna?
Yeah, Donna is unfortunately from Clyce, has got technical issues today, so there is a question from the waiting list paper. We appreciate there is CNA, DNA category, but is there a mechanism for the Health Board to understand any linkages with transport? We heard in the CSP event in Tenby that people using the non-emergency patient transport system sometimes have to deal with last-minute cancellations and cannot rearrange. Is there a data on this that can be explored further?
Which I think takes us back to this whole question that Anne raised, which is just about, an awareness of where patients are located, how they travel, and a coordination between that and any transport service is absolutely essential. It feels to me there's a responsibility for us to get those patients into the room, not just for them to rock up when we tell them they need to be in a room. We have a responsibility to help those patients get to the room. And I'm surprised it's just 19%, frankly. I'm surprised it's 19%. Seems to me these examples are just horrific, frankly. They're just unacceptable. Absolutely unacceptable. And the bit that I think you're right, Ewan, it's a system-wide issue, so it's about the system. But it's also about people taking responsibility for the kind of work they're engaged in and how they connect with the patient. This is about this organisation's values and what we believe in and what we think is the right thing to do. And it seems to me there's a disregard for the patient and for individuals inside this process, which is absolutely unacceptable. Because actually, I know the majority of people delivering services do their very best to regard the patient in the best possible way. What we see here is a system that actually places the patient at the bottom not at the top of a process. Unacceptable. Just completely unacceptable. Phil, and then we'll come back to Gareth.
Do you want Gareth to come in first? I don't know who would.
We're going to come to Anna, then we'll come to Gareth, and then we'll come back to Phil.
Yeah. Thanks, Chair. And I think this is such an important issue for the board to air in its meeting today, and clearly something we all feel passionately about. I'm sure most of us around this table who live on this patch can cite examples in our own lives of circumstances like this. I know I certainly can. So I congratulate Gareth for the humility that you expressed at the beginning of this item, Gareth. I think that is exactly in line with the values of our organisation and the values we wish to communicate in all communication with our patients, including in written form. And in fact, I have had some interaction with Al Wenner recently about the tone of our letters. But I suppose just to bring a slightly different perspective on this, I'm curious about whether what we see in our communication sometimes is actually a flag for the level of anxiety that exists in our organisation about hitting these targets and these deadlines, because what we desperately need to do is fill every available piece of clinical capacity we've got to get through the volume of patients that we have. And then when we are feeling this intense pressure, because we know we have for some services exceedingly long waits that are over time doing damage to individuals, that we feel this, and that anxiety then becomes evident in the way that we transact our business. And it comes from a place of good intention, but it's lost in translation. And I think when we think about this as a whole system, we should countenance the possibility that this is a reflection of the scale of pressure that our staff are under to get people through the doors, and that in their determination to do that, any one of us could lose sight of the human at the end of that piece of communication, who for them it is their world, for us it's just another day in the office. And I think we really must take account of those broader systemic drivers that may, at least in part, explain why we're not getting this right at the moment. Given that there's a suggestion that CUSEC should have a role in supporting the development of this work, I wonder, I'm happy to make the offer, Gareth, if it's useful to you, to meet with you or whoever the right person is to talk through what CUSEC would expect to see in the next iteration of this paper, so that we can get on the same page and make sure that that we're all pulling in the same direction with this.
Thank you for that. I think you're being generous. I think you're being a bit generous. I have no doubt you're right. There is pressure in the system to make sure that we optimise times, and that is quite a complex business. It just feels to me sending a letter to someone that's poorly written or is badly articulated, that's not about being under pressure. That's about being negligent and not really putting the patient first. So I think it might be a combination of reasons.
Yeah, it's not to excuse it.
No.
To understand what we might need to do to make the difference. Yeah.
Point accepted. Yes, please, Gareth.
Thank you, Chair, and thank you to all the independent members for sharing those experiences, which are totally unacceptable. I offer the most sincerest apology on behalf of the Health Board to those patients, their families, the residents of this Health Board. We have to do better. And the focus of the work, which I really welcome Anna's offer to sort of agree and define those terms of reference, really, as to exactly the scope of the work that we need to undertake. I think that, I really welcome that. There are clearly deficiencies which have been described by the various colleagues around the table. I think now it's what we do about it, how we change things, how we improve things. My commitment to the board is that I'll do everything within my power to improve the offer that we have to our patients. I know we can do better, and we will do better, and we will come back at a point in time and update the board on the progress we've made, because unless we change things, we have to change things. So I want to be able to come back and talk about the progress against what we've agreed will be delivered. And happy to take any further questions. But if any of the affected patients, I appreciate that they've kindly given permission for their stories to be told here. But if any of those patients would welcome any contact from myself or anyone else to provide any support, because I recognise that they've had distressing experiences, and to receive a letter that expresses pleasure in a diagnosis of cancer is completely unacceptable. However that letter ended up being sent, it should never have been sent. So please do reach out to your friends, family who have shared their stories, and if they need any support, you can contact me directly and I'll make sure that that's put in place.
Thank you, Gareth. Hugh, and then I'm going to come to Phil.
Thank you, Chair. I'm very conscious Gareth has offered a fulsome apology there to people affected. But this isn't just an operational challenge, this is a collective endeavour that we need to respond on. Some of those challenges, I think we can provide some support in through digital services. I think there's a clinical leadership challenge here. I think there's a collective challenge for us as an executive team to wrap support around the work that undoubtedly will be led through the operational team. But I think we all owe it to our patients to support that.
Thank you very much.
It was just to concur really and add to that from the clinical perspective. And we have got an infrastructure that we can utilise going forward. We've got a waiting list support service that's focused on planned care at the moment, but that does provide a single point of contact that not just allows individuals to get to communicate with us and get advice, but it also provides advice on lifestyle, prevents deconditioning, enables people to remain healthy while they're on a waiting list. So I think that was the conversation that we've had, is that we need to make sure that it's a collective response to this. Yeah.
Thank you, Sharon. And then just to finally.
Diolch, Cadeirydd. Yeah, look, first of all, just wanted to add my apologies to the people who've had that experience, and also other people who will have had similar experiences. It's something that we had a discussion about last week as an executive team in terms of some information that Sharon's team brought to our executive team about the experiences of our public. I think for us, thinking about our values, as you've said, this is very much embedded in the kind of customer experience or patient experience that we want to provide. And clearly we want to provide much better customer experience than you've just described. It's kind of the antithesis of what we are about as a board. I think, like Hannah, I think we do need to be curious as to the reasons why this is happening. And I think when we met as an executive team, there was a feeling that we all needed to contribute to supporting this. We'd already planned for a group of executives to consider this together, so they can work with you, Gareth, because we will need our clinical execs as part of that. We will need to consider what digital AI and tech can offer in this space. But fundamentally, we have to improve this because so many, of our nearly 400,000 population connect with us through this route, and we have to get it right. So.
Thank you, Phil. So I'm suggesting, in terms of moving forward, we acknowledge and note the content of this report. We cannot take assurance from this paper. It just doesn't give us assurance, so we are not taking assurance on this paper. What we are intent on doing is supporting quality and safety to kind of take the lead on working with Gareth to identify the basis for a much deeper review of this service in its totality. So accepting what Hugh said, it's much broader than just a single function. It's a much broader space in which we need to understand the whole nature of how we communicate with our patients in these circumstances. So we need to explore that. I want to see not just an exploration of that and then a published report. I want to see a remedial action plan that gives us as a board an assurance that actually this is being addressed, and we will not go on hearing these messages from patients. Exceptions might be the case, but the fact that we can sit round this table and bring to mind at least several examples says to me it's much larger than we imagine, and we cannot tolerate that. We cannot tolerate that. So I think I'm discharging that responsibility to Quasec to both meet with Gareth, understand the nature of that review, and then ensure that what we can do is action take any action that we think is necessary to address any of the challenges that lie within that. Accepting the fact that it might be, as you indicate, broader, and it might be about the imperative to get patients seen. We have to put the patients first. Okay, thank you, Gareth. I'm going to close this item. Let us move to our next item, which is improving people and community experience. Sharon.
Diolch, Cadeirydd, thank you. So this report reflects our ongoing commitment to listening to the voices of our people, patients and staff and communities, and it places their experience at the heart of our quality and improvement journey. And I think it's important to note that this reflects what our service users are telling us, not what our clinicians or our providers are as an interpretation of that. So you'll note that some of our system gets very positive feedback. You know, the report says 86% of people are happy with the care that they receive, but some feedback is less positive than that. So we know that there's more to do. You'll be aware that over the last year we've changed the format of the report in line with the Always People and Experience framework, and also with enhancements to the civic system, which has allowed us to get more richer and actionable insights into some of the information that we are receiving. And you'll see from the report today that we've now been able to provide some information around demographics, such as gender, age group, disability, religion and ethnic groups within are represented. And I just wanted to pull out really in terms of around, I was over 5,000 responses in this report, and yet 40% of respondents report experiencing some degree of limitation in their day-to-day activities due to health conditions and disabilities. And I think this insight is really important for us really to help us to support services in tailoring their provision to better meet the needs of individuals using the services. And there are some examples in there of what we've tried to do to respond to that in terms of using sensory rooms, in terms of delivering ear defenders and cutlery, etc. So I think that was quite remarkable from the introduction of that demographic data on this occasion. But I guess the purpose here is around gathering information that's about learning, and the report does highlight areas that require attention. And we've already had some discussion today around ambulance handover, for example, urgent and emergency care pathways, waiting times, and I think it's important, we've talked about AI and waiting lists, and I think all of that is responding to what our people are telling us about our services. So the report contains a lot of information, but I'm happy to take the report as read, Chair, and respond to any questions that may arise. But it was just to conclude that this reflects our ongoing commitment really to listening to the voices of our people, and placing their experience at the heart of what we do, and also recognise that this is congruent to the duty of quality under the Health and Social Care Act as well, so that the aim is to ensure that we are transparent reflection on how we're learning from this feedback as we progress in our journey.
Thank you. Thank you very much. Now, I'm not proposing we have a lengthy discussion about this. partly because I want to preserve the time we need to discuss the next paper. So it's really comments by exception, as opposed to, there are things I think we might want to say in the long term about how we capture patient experience and use this, but we can do that at a future meeting as opposed to use this space now. But Rodri and then Chantal.
Just very briefly then, looking at the 10 reasons of concerns, I think 16.5%, I suppose the response rate of that is quite good here, but I'm just wondering the 10 reasons for concern, 2 of them were delaying diagnosis, incorrect interpretation of results, and medication management. Obviously they've come up quite a few times to be in the top 10. Just want to know the learning behind this, and firstly, regarding whoever the clinician was, or is there any trends in that? And also, are we doing that detailed background check, and also bring him to one side and making sure that they are aware of the issues as well? I just want to have that reassurance, and as a board, we should as well. I think that's a very important point raised here.
Okay.
Chantal.
Diolch, Cadeirydd. In addition to what Rodri has said, I know I've asked this question before. You know, when we hear these sort of cases on the Listening and Learning Committee, we've asked about how does that feed within our education and training strategy and the plan to deliver that. And I'm not sure whether we've received an appropriate response to that, because when we look at this particular report, I'm sure if we go back the few meetings that we've had, we probably would see very similar concerns being raised. So I think it would be good for us to have some clarity around how does it feed within the education and training strategy.
Both points very, very helpful. Sharon.
Thank you, Chair. Thank you, Rodri. Thank you, Chantal. In relation to listening and learning, Mark might want to come in, but if I cover off your question, Rodri. I mean, in terms of professional governance, clinical professional governance, we've got regulation and revalidation processes in place that will allow us to either track clinical outcomes of individual clinicians and audit data as well that will identify where people are not performing outside of the peer group, essentially. And we've now got the Quality Safety Intelligence Group that reviews all that data intelligence, including, for example, CHKS data, which reports patient outcomes and so forth. So we wouldn't call a name out in a public forum, but we would address that individually with the clinician and with the manager as well in that space. My response, Chantal, in terms of your question, which is a very valid question. I mean, we are assured through listening and learning that you used to chair, and now Mark has picked up the chair of that going forward. I guess in terms of feedback, it comes through to Quality Safety Experience Committee. And last year we had feedback on the equality, diversity and inclusion, including the Ombudsman's thematic response, etc., cancer services, maternity services and management of inpatient falls. And at that forum we've got heads of service and clinicians, and they hear that feedback firsthand. In terms of communication, there has been linking it back to education, identified that there is a need to provide additional training to some individuals in that space, and that's being provided, but maybe what we need to do is just strengthen that to make sure that we maintain that link going forward.
Mark, did you want to add anything?
Yeah, thanks. I think it's a good question, Rodri. I mean, there is a strong governance system around clinical performance and specifically speaking about doctors, there is an appraisal and revalidation process that I'm responsible for. Any complaints or issues are fed back to each individual clinician. And if that is more a larger issue, then we have an appropriate system to manage that ultimately I am responsible for. Hopefully I can assure you that the numbers of issues we have with clinical competence is actually very low. What we tend to see more is about behaviour. That's the issue that we tend to see with clinicians, and there may be reasons for that, as we described, to understand why clinicians don't behave well, but ultimately we sometimes have to manage those formally. As to the Listening Learning Subcommittee, which I've been chairing for a while now, and it's a real pleasure to chair that. It is a real rich source of information and I really enjoy chairing it. But I think yeah, the potential issue that we're describing is the so what. We've now began to theme how the committee is structured, such that we focus on something specific, and that's why, as Sian's paper references, we've looked at communication. But it's always then, how are we going to improve communication, which is multifaceted, and engage everybody in that. We do feedback all the outputs, and we know that goes into our governance system. But I think we haven't got a good answer yet how we take forward these large themes and show systemic continued improvement. But we're working on it.
Okay, just to close the item, there's echoes in this paper we receive every board meeting. There's echoes between this and the earlier conversation about escalation, which is we look at the data, but actually, does it give us the assurance that actually the very question that you're trying to answer, which is, okay, so what happens as a consequence of this? We never know and we never see. We look at the data and somehow we're supposed to be assured that because lots of people generally think it's pretty good, that that's okay. But actually, we are more interested in where it's not okay than when it's okay. There is something about us thinking, it doesn't empower us, this paper, to be able to have an insightful conversation about how do we make things better across this health board for patients who are receiving these services. And I think the questions are the right questions to have asked in this instance. So I want us to think more about how we present this paper in the future. To be frank, I do not need to see this data. I can see this data outside of the context of this board meeting. What I would want to see is a paper that says, as a consequence of what we know about patient experience, what are we doing differently to understand how we meet or respond to these needs? Because back to your point, Mark, is it within a particular clinical discipline? Is it within a hospital? Is it a particular time of the day? Is it with regard to particular kinds of patients? Is it a particular individual that kind of leads this work or leads us to understand why our services are suboptimal in these circumstances? And that's what we need. We need the analysis of this data for us to be able to have an informed conversation about being assured or not assured. It's not the data itself that we're assured by, it's the actions and effort of the organisation to address those issues where we're delivering suboptimal care and patients are complaining about it. Is that clear? Okay, thank you. Let us move to our next item, and that is to Prince Philip Hospital Minor Injury Unit options. Mark, I'm going to hand over to you.
Thanks very much, Diolch David. So I wonder if I could start off by introducing colleagues who've joined us here today. We have Dr. John Morris, who's the clinical lead for the Minor Injuries Unit. We have Sian Edwards, who's the lead emergency nurse practitioner. We have Dan Warm, who's our head of planning, and Nicola Cachero, who's our head of engagement. And not only do I want to thank them for joining us, but I think I'd like us as a board to thank all of our staff who've been involved in the process to date. I think it was a significant challenge to us to bring the output of our options development process and our public consultation to board today, but through an immense amount of work, and you'll see that in the papers, everybody's brought that. So I want to thank you all very much. It's really important to us as a board and to our communities that we've got here today. So, as we know, in September 2024, the board adopted a temporary service change of the opening hours to Prince Philip Minor Injuries Unit, 8 a.m. to 8 p.m, 7 days a week. This was due to safety concerns, our inability to staff the Minor Injuries Unit with doctors, and that patients with major illnesses were presenting to the Minor Injuries Unit. The board decided to develop and appraise a list of options for a long-term model for the service. And these options were brought to board in March of 2025, and a formal public consultation was approved. The options that were developed with staff, our patient representatives, such as Slice and SOSPAN, and I want to thank everybody who've been involved with us. The principles that we used to develop those options were that our care should be safe, sustainable, accessible, and kind. So I'd like to remind everybody what the 4 options were that we developed. Option 1 was a 12-hour doctor-led unit, which would be open 8 a.m. to 8 p.m. plus 2 hours. Option 2, a 14-hour doctor-led unit, which would be open 7 till 9 plus 2 hours. Option 3 was a phased option, where we started at 12 hours, we then moved to 14 hours, and then moved to a 24-hour service, which was how the service was provided before the urgent service change. And then option 4, which was a 14-hour urgent care centre, which was open between 7 till 9, and then 2 further hours. I think it's important to remember to remind everybody what was not in scope. Changes to the acute medical assessment unit in Prince Philip, which has remained unaffected and continues, as you'll see in the data, to work very consistently. Re-establishment of an A&E, an emergency department in Llanelli. Closure of the minor injuries unit. We are very much committed to keeping the minor injuries unit open. Relocation of the minor injuries unit to any other site apart from the Prince Philip site, and also any other options that we had previously excluded. The 12-week consultation has run from the 28th of April to the 22nd of July, and during this time, members of our public, service users, health board staff, partner organisations and other stakeholders were invited to give feedback on the 4 options and anything else they felt the health board should consider, including other potential options. We have sought views using multiple methods and in multiple languages. Also, easy read versions, audio versions, and British Sign Language versions have been made available. The consultation promoted accountability and decision-making and has therefore been a dialogue with our public. The consultation, I need to remind everybody, is not a referendum. It is not a vote. And thus, options with the highest score must not automatically be considered to be the favoured option. We must consider all the other information that we have available to us. We have sought external assurance during the process, and this has occurred at 2 points. A midpoint review and a closing review by HYCO, and these reports can be found in Appendix 2. Our output report, which you'll see is a very extensive documentation document, is at Appendix 1, and that gives the full evidence base for our consultation. So what has been our response? We've had 735 responses to our main consultation questionnaire, 9 easy read responses, and also we've engaged with a further 700 people at multiple face-to-face and online events. And a number of themes have resulted from these meetings, and again, we document this in our paper. We also want to thank a number of stakeholder organisations and political representatives who've given written responses. CLICE, SOSBAN, Swansea Bay University Health Board, Llanelli Rural Council, and Mr Lee Waters, who's the Senate member for Llanelli. We also want to acknowledge 2 petitions, one carried out by SOSPAN, which gained 13,000 signatures, and one presented to the Senate Petitions Committee with 969 signatures. Following the end of the consultation period, we've carried out a period of conscientious consideration, and that has resulted in the final report. This final report has been shared with a number of groups and also with the board. 26 additional options were received via our various engagement methods, and these were aligned to our 4 options as described in the paper. These options were assessed at a hurdle criteria workshop involving those involved in the original options group on the 19th of August. 6 options passed the hurdle criteria. Now, you bear with me a bit in describing these. So option 1A, which is aligned to option 1, is access via 111 only. Option 2A is option 2, but via access via 111 only. Option 2D is where the opening hours would be 8 till 10 plus 2. Option 4A, which is aligned to our option 4. 4A, which is 12 hours plus 2 hours, open 8 till 8. Option 4B is access via 111 only. And option 4D is where the opening hours would be 8 till 10. As attendance at the second options development session was lower than the first, we have shown scoring within the paper using a percentage scoring. And the summary of this, as you can see, is there was little difference between option 1, option 4, option 4A, and option 4D. So which of our options are deliverable? And I think this will now get us into the important discussion.
So in terms of workforce, options 1, 2, 4 and 4A we consider to be deliverable. However, options 2D and 4D are less deliverable, as the hours be less attractive to our staff, and we can have a conversation with our staff about that. Options 1A, 2A, 4B would need additional recruitment, and options involving the 111 element would be considered as difficult to deliver. And I think that is something that we particularly want to stress, is that whilst we very much believe in being able to schedule unscheduled care, us being able to deliver within 6 to 12 months access via 111, not just within Prince Philip, but potentially across the whole of our emergency care system, we think would be extremely difficult to deliver. Option 3 would be deliverable, probably within the first 2 phases, which would be to open for 12 hours and 14 hours. But we're really unclear about whether we would ever be able to return to a 24-hour model, and of course whether that would be the right thing to do. Our inability to staff a 24-hour model was what has got us here in the first place. And in the last year, we haven't seen any changes in our ability to recruit. So I think it would be really difficult for us to be able ever to return to a 24-hour model, should we decide that. Within the paper, we set out projected costs of the options, but with quite a number of caveats, and a number of options are not able to be costed currently, particularly as some of the options, particularly options 4 and 4A, would need some capital investment. We would need to look into that later. Also within our annexes, we have the EQIA, the Quality Impact Assessment, and the Quality Impact Assessment, and I think what I'm now going to do is firstly to ask Hugh to talk us through about the financial sustainability of the options, then Sharon to talk us through the Equality Impact Assessment and the Quality Impact Assessment, and then I think I'm very grateful to hear from John and Sian about the clinical view and also about the views of the clinicians within the department.
Thank you. Thank you very much. Very helpful. Hugh.
Yeah, thank you, Chair. I'll just focus in on page 15 of the document, which outlines the costs of the options we have there. Clearly, historically, we have been operating within broadly the option 3 financial parameters from a budgetary perspective, but of course because we had challenges in staffing and weren't able to have staff on a number of occasions, we were spending broadly about 3 million of the 3.6 million that was in there. We're currently broadly in our forecast for this year broadly spending what option 1 is looking like, which is the 2.5 million. So there's kind of a half a million implicit saving that we've got in our position for this year, that any of the options from there would build on in terms of the costs we would need to reflect on into future years. I don't want to prejudice the conversations of the board in any way. We would need to reflect on then the financial challenge that any option would then present for us as part of our financial planning for next year.
Thank you, Hugh. Very helpful. I'm just wondering if there's an analysis of value as opposed to cost. Mm-hmm. So in that kind of value-based healthcare approach, would we understand where we are spending money, what delivers the best value in these circumstances?
Yeah, Chair, what we've got here is purely a cost base. Naturally, and we had this discussion as an executive team, when we get into discussing the opportunity that option 4 gives us in terms of the broader system impact that could have on improving urgent emergency care more broadly, that's certainly something we would want to consider as one issue. But there clearly is a there's a big differential between operating on a 12-hour basis and a 14-hour basis, and that additional 2 hours does cost a considerable amount extra for us.
Fine, okay. It's just I feel what's really important for us here to think about is what generates value in terms of benefit against the cost that it creates. That's going to be quite important for us in our considerations. Thank you, Hugh. Sharon, did you want to come in?
Just, yeah, thank you. Thank you, Chair. Around the quality impact assessment process, the panel did meet to discuss the QIAs that had been submitted against each of the options. And as you don't know by now, you're familiar by now, that we assessed them against the domains of the duty of quality, which is safe, timely, effective, efficient, equitable and person-centred care. And I guess the options, there was little difference between option 1 and option 4 and option 4A, which was congruent with the analysis within the paper. Some of the options were scoring significantly in the safe care domain. But I guess from the panel's perspective, the most promising option, I've seen as the most promising, was that of option 4, because it was praised really for the broader scope and the potential to alleviate pressure on the A&E departments across. So, yeah, so there was quite a detailed discussion there.
Okay, thank you. Very helpful. Anne, did you want to come in? I'm conscious you would have a perspective from your trade union background on the felt experience within staff in that area.
Thank you. I actually contacted the staff. I phoned them and had a conversation with them. And the conversation was that, I'll be honest, they couldn't see a 24-hour service being managed safely. The work they're doing now, they feel it's good quality, good care. But the conversation went then to SDEC, where they feel that if they could incorporate a bit more SDEC, they could do more, because at the moment SDEC is seeing anything from 17 to 19 patients and delivering treatments and treatment results and tests and things like that. And the conversation then led to having more of that incorporated in what they do. But staffing it the way they do now, they were saying, oh, we do 8 till 8, and that's 12 hours. And I said, no, but you don't finish till 10, so it's 2 hours of dealing with the patients. So they're actually doing 14 hours, but they're doing 12 hours of patient deliverable care, and then it's kind of using up the last 2 hours to make sure the patients or whoever's in the department are safely allocated. So, but yeah, they really want a result today, because they just want to get on with their work and know where they're going in the future. And that's what I heard yesterday. Okay,
thank you. Very helpful. Right, we're going to come to our key players here, our practitioners with their hands-on experience of this. So you're both very welcome today. Thank you for joining us, and thank you for your forbearance, because we appreciate this period of consultation, as vitally important as it is, has also perhaps created that sense of not being certain about where the future lies, as Anna's just indicated. You're very welcome.
Okay, diolch, Bwrdd Dda. Thank you for all the comments that have been made so far. I think it's worth going back to a year ago when a decision was made on a temporary closure overnight to the department. There was a lot of worry, not only from myself, but the staff and the public with regards to how that might impact. It's worth saying that since November of 2024, I do feel like the minor injury unit in Prince Philip is delivering a safe and effective level of care to the patients who attend. And a 12-hour model certainly works. We did have a recruitment drive to fill empty slots within the unit, and we were successful in recruiting 7 additional GPs, but again, nowhere near the number that we would need to return to a 24/7 service. So I feel, and Sian will be able to talk more about the nurse practitioners that work hard within the unit. From a GP point of view, I think a 12-hour service is deliverable long term, both from a safety perspective and effectiveness, but also value for money. And I think we are excited by the prospect of a urgent care centre model, which would be a fairer reflection of the work we do in the minor injury unit, and also will give the people of Llanelli and further afield who attend a really good service to be proud of. So I'll hand over to Sian now for any nurse related.
Good morning. Thank you for having me. From an emergency nurse practitioner perspective, they're now able to deliver safe and effective care to the population of Llanelli that present minor injuries. There's been some challenges around the triage nurses and the redirection process that's in place there, but they're always supported and backed up with the GP on duty to guide them in that redirection and where's the best place for that patient to be. From a workforce perspective, we certainly need to develop that, not just in Llanelli, but across the whole health board, to just ensure that we have a sustainable minor injury future. Because of the workforce, we're all getting older, so we do need to replace that workforce and deliver effective training that we've already started in the last 2 years.
Thank you very much. Thank you very much both for your perspectives. So, colleagues around the table, board members, let's just have a moment of clarification on any questions you've got around information we've received that you've not understood or you feel you need to explore more deeply. So, any questions or thoughts? Michael? Michael, just welcome. I'm sorry, I know you came late. I'm sorry you've been well, it wasn't my fault, the traffic, but I appreciate you've been sat in traffic for a long time.
Yeah, I apologise, Chair, but the M4 was closed and so quite a diversion. But I'm here. I'm very keen to be here for this item as well, Chair. So I just want to clarify the option 4, the SDEC option. There's a lot of talk about the kind of good ripple effect of that. So in very, very simple terms, what is that and why does it have a wider impact? It's suggested a wider impact, wider beneficial impact. Why is that exactly?
So I think currently we are stuck with the type of services we can provide from a urgent primary care type patient. We have a minor injury stream and we have patients that go to either the acute medical take or the current same-day emergency care team. But we have a middle ground where at the moment patients will often be redirected somewhere else, such as their own GP, a pharmacist, or quite often to ED. And that's what we believe the urgent care centre model will mitigate, is to try and lessen the numbers that we have to redirect somewhere else. So there'll be a minor injury stream, a medical stream, and then this middle bit, which we'll be able to hopefully take pressure off primary care services and ED that we know are under immense stress. So hopefully that's the bit that we're trying to, with the option 4, help with.
So the offer will be broader, John?
Yeah.
And more streaming, more clinical streaming. Okay, thank you. I know that Donna from Llais has also come in with a comment.
Yep, so Donna's asked, for PPHMIU to make the service change successful, there needs to be continuous education and engagement with our public about what fits within the remit of an MIU. Without this, there risks being a creeping remit which will create challenges for professionals and mixed messages for the public. Does the Health Board have a plan to achieve this?
A very good question. And Alwena, do you want to come in?
Lovely, thank you, and thank you, Donna, for the question. Yes, in short, what we've tried to do during this period of change, temporary change, is to seek support from our communities by asking them to consider what they have as a condition and look at that by accessing the service online to check your symptoms. Failing that people phone 111 to access support as to the best place to be. And then if it's a case of breathing difficulties, a suspected stroke or a suspected heart attack, it's 999 and that people will divert to the most appropriate route. This is something that we'd seek to continue to reinforce going forwards, recognising that the condition that individuals may face may need to go to different places. So it's definitely part of what we will be seeking to educate upon, both at the point when we make the decision and that decision is enacted, but also in the meantime to reinforce and ensure that people know where to go for help when they need it. But yes.
Thank you, Alwena. Michael, do you want to come back in?
Yeah, just building on that point, which I think is a good point from Llais about kind of continuous education and making sure people understand what's required. being a bonnet I've had a number of times is the worry about transport, okay? And it's mentioned a lot in the, it doesn't come out, this is no criticism, it doesn't come out so fully in the paper, but it's definitely there in the finer detail. So I wondered if, as well as what Alwina said, which is a very good answer, and I totally agree, is that we have some kind of commitment to keep under review and also to try and work more generally about how we as a health board can influence better transport policies linked strategically across the region, because I think that feeds into a lot of the concern of the population. And I think this is our opportunity to take that forward, whatever decisions made today. Okay.
Very important point. Rodri, if I'm not mistaken, isn't the responsibility for transport being devolved to local authorities?
Depends on the routes. Sorry. Well, no, I think it depends entirely on the routes, the smaller roads. But when it comes to the trunk roads, that is still the Welsh Government function. So it depends on routes undertaken, and also perhaps initiatives within the local authorities. They have got other forms of transport to these specific locations.
Yes. Thank you. My point is, I think it's evolving, Michael, and I think I have a sense that in the future it's going to be there'll be more opportunity locally to be able to plan some of those systems and services in the way that they have been in the past. I mean, true to say, transport is not our business, but patients being treated is our business. So there is an absolute link between those two things, and we do need to have a greater understanding of the hardship and challenges that people experience, especially when we think about the size of the health board and people having to travel quite some distance and at inconvenient times to be able to access the treatment they need. So we do need to become much more focused on transport, and I think, Lee, that's already featuring in some of our work around the strategy, and it certainly will around the clinical services plan. So you raise an important point, as does Donna. Anne, you wanted to come back in?
It's linked with transport in a way. It's the signage. You know, you go to Llanelli and it still says it's an A&E after all these years. So if we're saying, right, this is a minor injuries or an integrated care centre, please, the council need to adapt the signage. We're giving false information. We're telling them what a minor injuries is, but we're telling them this is an A&E and it's the signage.
Very good point. And that's just basics, isn't it, in terms of making sure we get these things right.
James and I identified it over a year ago and still nothing was done. It was identified before we did and still nothing was done. So it's something that once this decision is made, we need to involve the council to change the signage.
Okay, I'm challenging exec team members to literally take a screwdriver and remove the sign. It is that simple. It is that simple. Okay, Eleanor, please.
Thank you to everybody in the team for presenting this paper. One day I'll remember to move the microphone towards me before I speak. I think there's some really good things in this paper. One, acknowledging the community input and the number of responses we've had. As independent members, many of us are community members or even not directly so responsible for listening to the voice of the community, and that is really, really important. I've also been professionally and personally recently into MIU. The staff there are very keen to have a decision, and I think in terms of recruitment, retention, and providing a happy staff for a quality service, we do need to make that decision today. I think the other important thing for me is it's not been an A&E for a very long time, and my father used to write letters to the Welsh Government about it, so I do understand the feeling locally, late fathers to do that. What we want is a really quality service for the people of Llanelli. John has described the combination of STEC with minor injuries. That would be different to what we offer in other places, but a really quality service from what I read in the papers. I think taking account of it being the second choice of those who responded from the community,
the clinically advocated position that provides a broad quality service, I am in favour of that combination of MIU and SDEC. I think an integrated care, it could be a great facility. It needs a lot of planning, it needs a lot of explanation, and we need to do that. When I was in some of the consultations, I could recite to you now what minor injuries does, because I spent many hours explaining what it is, and that's something we need to do as a health board more and more, building on the plan that Alwena said. It's a quality service for the people that use it is what we need to do that. I think 12 or 14 hours, it's whatever the clinicians recommend as far as I'm concerned. We're here because HIW told us we weren't safe because we couldn't recruit. So let's not forget that. However many hours we think may be desirable, the reality of recruiting into that space, it proved difficult and quite impossible to do. So I really want to be supportive of that option 4, recognising it's clinically recommended. It's the second most popular answer from the responses, and actually in a model that we aim to get to in a long time of a social model of healthcare, it is an integrated service in one of the most populous areas of our area. So I think, for me, I'm supportive of that option.
Thank you, Eleanor. Very helpful. Ardiana, and then I'm going to come to Lee.
Diolch, Cardidd, and thank you. Several times colleagues did mention the outcomes of the consultation and our concept of whether it's value for money. Once was mentioned, and then it was mentioned the value for the services. And I thought it's important that we really explain and contextualize what we mean about the outcomes of the consultation and what we as a health board, as a public service, have a duty to spend our public money in, and relating that to that it's a value for the health of the population that we serve. And in the preliminary data and the ongoing monitoring of the health outcomes that we have seen during this period of closure of the night time of service of the MIU, we have not seen any worsened outcomes for the population that the MIU has served. We know from the evidence and from what Welsh Government is proceeding with definition of the MIUs and or the outpatients care is that it's a better service for the needs of the population. It's also important to contextualize what the opportunity cost for the very population is. I think the opportunity cost of providing something that does not deliver better outcomes is for those very patients that are receiving that service, they are potentially or concretely missing out on a better service elsewhere, perhaps as what we will need to do with the due diligence and wraparound service, travel to elsewhere, but also the opportunity cost of that money being spent elsewhere. And our public very clearly got the message during COVID pandemic of don't take the risks because that bed will be needed for someone who needs it. And I think we will need to be doing more with education, with engagement, to actually get the public to understand that they will get better service in the frame that we are looking at, and that the consultation has showed as the second best option, but also the very limited budget that we have will be spending better for more advanced services elsewhere. Diolch.
Which is exactly the criteria I think I was referring to in response to Hugh, which is how do we ensure that the money we spend delivers maximum value in terms of patient health and patient well-being. Thank you, Ardiana. Lee.
Thank you, Chair. Diolch, Cadeirydd. So, just a few points I just wanted to make. So, firstly, I wanted to thank Sosban and Llais and other members of the public for their involvement in the options development process. That has been very constructive and very helpful over that period, and I guess just to reflect that has actually led to option 4 being on the table today, because that originally wasn't one of the options that we were considering, and the insights and ideas from those stakeholders and our staff has allowed us to think a bit differently about it, which is obviously very welcomed. There were a couple of points I just wanted to reflect on. So I think Mark made the point earlier about 111 and that being an option or a sub-option across a number of the decisions we've got today. I think where we want to get to as an organisation is allowing people to schedule appointments as much as possible. That, I think, is easier for the service to manage, but more importantly helps people access services in a more timely fashion, but also know that they're going to the right place. So one of the key messages we've heard through consultation and previously was that people are confused by how to access the services and which service that they should access depending on their conditions, which is completely understandable. You'd have to be quite, have quite a lot of clinical knowledge to determine that answer absolutely correctly on every occasion. So I think that is a direction we'd want to go in, but I think that's probably a discussion for another day, because we're not in that position now. But I think just a signal that is where I would see us going. And then I thought I'd just give a bit of perspective on your value question, Chair, because I think that is a really important point. So one of the things for us to think about is that whilst we've had reduced opening hours over the last 12 months, we haven't actually seen a reduction in the minor injury unit activity over that time. So what that means is we're still meeting the needs of the population, but in a more controlled and managed delivery, which has actually brought benefits to our population. So you can see from the data that our 4-hour and our 12-hour performance has improved. In fact, our 12-hour delays have been virtually eradicated. We also see that in the patient experience, that people are reporting a better experience, and as we've heard, it's also better from a staffing point of view. We haven't seen, which was feared, a measurable impact on Glangwili or Morriston. So what we're seeing is the patients that should be accessing a minor injury unit are accessing it and getting in a more timely fashion, whereas those that should be going to other services are now doing that, because we've got fewer majors, for example, in the department. So in terms of the value we're getting then from that service, I would say it's been greatly enhanced, because we're treating the right people in the right places at the right times and in a more timely fashion. On the point around option 4, I think there's one aspect for the board to be aware of, which is clearly that does present an additional cost over and above our current run rate. But on your question of value, we do have a parallel ambition to move to 7-day SDEC services across our sites, and the reason we want to do that is because we recognise there's an opportunity to provide more timely care to patients on the day, on the weekends, and actually that will be a better service for patients, but also would reduce unnecessary admissions and so on, which brings a system efficiency point of view. So whilst we haven't captured that in the paper, I just wanted to reflect that actually we would anticipate that would bring some efficiency and value gains as a result of that, and obviously that's the direction we're going in across the other sites, but we'll bring that back to a separate board discussion. You'll remember the Karen Brown coming to a previous meeting to describe that. So it's aligned with the direction of travel more generally. And then the final point I just wanted to make around opening hours. So I think one thing to be cognizant of is in that ambition to move to 7-day SDECs, we are envisaging SDECs aligned to the demand patterns, opening potentially between 8 AM and 8 PM. So I think that gives us a bit of a steer as to how we might want to operate this new model if that's the direction we go down. So thank you, Chair.
Thank you, Lee. That's very helpful as well.
James had his hand up, Chair.
Yes, please, James.
Didn't know I caught your eye, Chair. So just in terms of support, so I've been working with the medical director and nurse director regards to some of the sustainability of the workforce and the clinical workforce models, and it was just to offer the support for option 4. but also that it absolutely aligns in terms of the more multi-professional clinical leadership, the multi-professional delivery of value services from different professions, along with the competency bases. So it feels absolutely aligned, and just really welcome the work that's happened. Thank you. Yeah.
Great, okay, thank you for that. That's adding another note of assurance. Maynard, and then I'm going to come to Phil.
Yeah, just two questions. James mentioned...
Adiana, shift. Great.
James mentioned workforce, and between option 1 and option 4, there's a difference of 14 whole-time equivalents. Are we able to recruit those 14 staff? You know, are they out there to recruit? And then the other thing I'm not quite clear on is the timescales to implement the various options. I know we've said that they need to be operating within 6 months, but are some of them easier to deliver within that timescale than others? For instance, you know, thinking again about the number of whole-time equivalents, could we actually recruit and train the relevant number of staff for option 4 within that time period, whereas with option 1 we've got the existing staff already?
Good questions. Would anybody, Lisa, would you like to address that?
Yeah, thank you. Thank you, Maynard. The team that have been involved in the work have said that they believe they can fulfil the staffing requirement within 6 to 12 months. So it would be a phased approach.
Thank you. Okay, does that address your issue?
Yeah, as long as it meets that criteria of 6 to 12 months. I was just worried recruiting and training 14 staff can be sometimes difficult
yes.
on our patch.
Sean.
If I could just come in there, the workforce model there would be merging the current SDEC model in with the minor injuries model. So some of that whole-time equivalent would come from our current workforce that we got and would be merged into one.
Thanks very much.
It feels to me as well, where we avoid some of the obstacles, the potential obstacles we've experienced currently in terms of recruiting into the MRU, is that the work pattern that we're recruiting into is one that's much more consistent with what people would want to work. So we're not having to overcome the obstacle of asking people to work in sociable hours or hours when they feel exposed. Or one of the anxieties we had was staff safety during this period. So we'll be encouraging more people to come forward because it's a pattern that they are more comfortable with working. Great. Okay, Phil, I'm going to come to you.
Diolch, Cadeirydd. And look, like Lee, I did want to just start by thanking all the staff who've engaged with this, all the public, Llais, Sosban, and also our elected representatives. We've had significant engagement, and I think the fact that we had a lot of alternative options. I think we said 17. Was it 26? 26. Okay, so we had a significant number of alternative options there, which we've taken through a process. So a big thank you to the team as well, who've managed this process, quite complicated process, to bring us the options today at board. We are looking for a service that is of high quality and is sustainable. And I was actually going back to your principles that you said at the start. So we need something that's fair, sustainable, consistent with our strategy, no unhelpful precedent, and safe. And it feels like through our discussion we've touched on most of those points. When I was hearing there about the urgent care treatment service, it feels like an enhancement in the way that our clinicians are describing this, like a streamlined service that offers patients both the minor injuries element, but treatment for illnesses that don't require necessarily coming into hospital. So I think, that's given the demographic and the need in the Llanelli population. I can see why that option has come forward as option 4. It seems like an enhancement on the option 1. And of course there is a cost to that, which we're all trying to reconcile given the challenges that we have. Having said that, it does, from what colleagues say, appear to have the opportunity to provide better sustainability and a higher quality offer to our public, and something that our staff, our clinical staff are recommending to us, and therefore is something we're more likely to be able to recruit to, because it will be a fulfilling role. So from where I'm thinking that the option 4 does seem like a really attractive option. I think in terms of the opening hours, I'm cautious personally about going for the additional 14 hours, because I'm in my mind thinking about sustainability of that option. It is something we could consider at a future date, but I think we need to make sure that we do something that is really sustainable. And whatever we agree to as a board, my suggestion is that we commit to an evaluation in the way that we have done in the past. I think that evaluation needs to, of course, cover patient experience and outcomes, but also an assessment of staffing and resource more broadly, resource implications. But those are my thoughts, Chair. But I do commend the process that has been followed here with the public so professionally by our teams.
Thank you, Phil. So, trying to draw this to a conclusion and reach an outcome, it seems to me there's a few things we should remind ourselves of. And Eleanor quite rightly reminded us that where we began this process 12 months ago was with acknowledging our clinicians were very uncomfortable with the quality of the service being delivered. They didn't think it was safe or it was delivering quality. And I feel we listened to those comments because they were absolutely central to delivering effective patient care, and also making sure that we cared for our staff as well. It isn't just a consideration that's about patients, it's about the people who work inside the organisation. So I felt there was a very loud and powerful message, and it was amplified by the fact that HIW had only, rather Health Inspection Wales had only, within the previous 12 months, also said it was unacceptable as a service. And I think we took the decision at that time, as radical and as unpopular as that decision was, we took that decision on the basis that we needed to have a safe, sustainable service in the long term. And I think what we've seen over the last 12 months is that we've delivered that service very differently. A diurnal service, a diurnal service as opposed to a nocturnal service, and actually, notwithstanding the fact that people have probably been a bit miffed and unhappy about the fact we changed this, the actual impact has been relatively little. We're delivering a very efficient service through the MRU at the current time, to broadly the same volume of individuals we were receiving. We were delivering against before, and also that staff involved in that are much more comfortable delivering that service. Seems to me to be, last year there was a degree that the service was precipitously on the edge of disappearing. Frankly, it was going to collapse, and now we have a vibrant service that people enjoy working in, and to which I'm sure we can recruit in the future. And we measured it against those 5 core principles that we start each board meeting with, in terms of its safety, its clinical safety, consistent with our strategy. And I think Lee has pointed out very eloquently where that sits in relation to our future direction when we think about this, not creating an unhelpful precedent, and ensuring that it's affordable and sustainable and fair. In terms of that affordability and sustainability, for me, there is that additional dimension to value. What delivers patient value? So with our very limited resource base, how can we be assured that when we do spend our money, it delivers the maximum benefit to our patients in the best possible way. And I think, Ardiana, you spoke to that as well in terms of ensuring that's the case. So I think when we think about the future, it's really important that we allow ourselves to kind of reach into the future and work out what is it we're not going to need just today, but tomorrow and the day after that. What is it we can grow or develop as a service that will allow us to meet the needs of the people of Llanelli. And we'll also work within the context of our strategy as we try to plan ahead. And you'll know everything we talk about is trying to move more towards primary care-based services, non-hospitalised services, services where we can keep people out of that environment as much as possible. And it seems to me the MRU and an ESTEC function has the opportunity to be able to do that, as indeed the evidence would suggest already when we look at our other units across the patch. So if we were to think about those broad, sustainable, those principles, decision-making principles that support what we need to do inside this space, then I think we are driven to option 4. It's not only evidence-based in terms of we know over the last year we've managed to deliver a safe, efficient, effective service to broadly the same number of people. It's an enhancement of that service. It will enrich that service. It will carry an additional cost that we will need to plan for in the future, but actually it will deliver additional value in the future, and it will create an opportunity for us to reimagine what we can do through that service as we look to the future. It's a platform for us thinking differently about health services in relation to the people of Llanelli, and I think that can only be a good thing. So my proposition is that we agree to option 4. Obviously, before I make that proposition, Mark.
Governance point. Sorry, Chair. Can I just check to be clear for the governance?
Yes.
Do you mean 4 or 4A?
4A.
It's 4A.
I would say 4A, the 12-hour service. And as Phil has indicated, we will evaluate this and we will review this decision, and it may be in the future. There may be a reason why we would want to alter that, but at the current time we will...
So it's option 4A.
It's option 4A, okay, for clarification purposes.
Just to be clear,
option
thank
4A.
you.
So I propose we endorse a decision to agree for option 4A. Now, clearly, a consequence of this decision is that a lot of people may not be happy with the outcome of this, and we're not here to be popular or to always make a decision that pleases everybody. Sometimes we have to make a decision that we think is the right thing for the board and for the people at Llanelli, which locally might not be the case. So there is something about the communication of this, and everything that we've heard, Donna and everybody else, ensuring that what we do is make sure that we provide increasing levels of education around people understanding what the service is about and how we deliver this service. So I think that is really important, that we find a way to improve understanding of what this service will be and how we will offer this service, and how it will change, and how we will enable patients to access this service for the right reasons. But Michael's point as well about transportation is deeply important here. What we have to do is start to understand how we can have a positive influence on how people arrive, not when or why they're arriving, but how they arrive at this facility too. So I think what we need to do, and I think you made it very well, Michael, I think we need to not just dismiss this, we have to actively and consciously think about the transportation challenges people experience when they try to visit this system, and think more broadly about how we might address that in the future, as indeed I think we need to do across the whole of the Health Board, not just in relation to Prince Philip and Llanelli. Any final thoughts or comments? Winston.
Yeah, well, it seems to me 4A will require some capital expenditure in order to enable it to happen. So we're going to need Welsh Government support in order to secure that capital expenditure, unless that's within our existing allocation. I think, Chair, I've got no doubt that this is the right result on a sort of value for money point of view, an investment for the right outcome of the service. But also, I think the additional work the additional 14 whole-time equivalents of 4A compared to option 1, which we're operating at the moment, it's going to be really important that additional workforce isn't through agency staff, that we try to make sure it's through bank and through straight recruitment. Otherwise, we may fall down the path of being sort of really challenged by Welsh Government on that.
Of course, points well made. So can I ask board members, are you happy, are you content with that as the direction of travel and the way forward? We would endorse the decision of...
Are you approving the preferred option for A? Yeah.
Is there anything you want to say?
Yeah, well, no, I'm just checking that we're approving that, because I just had in addition, I think you've drawn out some other specific things that are, whilst we're approving that option for A, we've committed to a number of things, which I just wanted to call out specifically. One of them is the evaluation that we would expect. I mean, at the moment I'm considering 6 months after operation of the model, and that needs to include both patient experience and outcomes, which will draw in the transport and staffing. I think that we've committed to a programme of work around the communication of this model with both public and staff. I think we've also, with Lee's point around 111, I think, which I think is an important point, because it is challenging for the public to understand how to access our services. And I think more and more we want to work with 111 to help public access, to help the public, enable the public to be able to phone 111 and understand where they are best suited to get their advice, whether it be remotely or to travel to one of our facilities. So whilst at the moment we might not have all that in place, that I think we want to commit to working further on. And the fourth point is maybe bringing Lee around Winston's question about capital, because I do think we need for the public and the board to understand the point about capital.
And your point about transportation.
And transportation, I think we will, I think 2 points. We need to include that in our evaluation, but we also need, as you say, to work specifically on transport.
Great. Lee, did you want to say anything?
Well, we've done some initial work on the design of the unit, or the redesign of the unit to accommodate the changes. So that was some of the work we did in the original development of the options. So there'll be another piece of work to be done now to take that forward in more detail. We'll assess the capital implications for that, and then if we can manage that within discretionary capital, then we will seek to do that. But obviously there may be a need for further conversation with Welsh Government. But we obviously propose that option, or that option has progressed at this stage because we think it is deliverable from a capital point of view. So we'll look to progress that.
Great. Okay. Hugh, did you want to say anything?
Chair, I just want to make the point very clearly that this does now represent an investment that we're making into this unit over and above what we are currently spending, and over above what we were historically spending on the previous model, because while the model was budgeted higher, we weren't obviously able to bring in staff. So it is a net investment that we are making in this unit. We'll then need to consider the impact that has on our plans for other services across the health board.
Yeah, thank you. A point well made. Okay. Thank you, colleagues. Thank you for your engagement in that. That's a difficult decision for us, but it's an important one, and I think I have confidence it's the right one. It's the right one. Thank you, colleagues, for joining us for the for the discussion. Great. Before we break for lunch, we need to cover up our next item. Gareth, you or Lee, you're going to pick up the operational delivery network and the Southwest regional pathology arrangements. Yes, please.
Thank you, Chair. Yes, in Andrew's absence, I'll take the paper, because I've been involved in much of the planning around the new facility. So board members will be aware that work has been progressing for some time on the establishment of regional pathology service in response to a number of key issues. They're set out in the paper, so in particular the state's challenges, workforce and the fundamental scale and sustainability of current services. Originally, the plan was to develop a regional laboratory for all of pathology services on the Morrison Hospital site. However, as the cost of that project increased significantly to 135 million or so, Welsh Government came to the decision to cease support for the development of that business case as part of a national capital prioritisation process. The more significant risks, state risks we face are in cellular pathology, and as the paper notes, that's particularly true in Glangwili. And at the March board meeting, we agreed to undertake an urgent piece of work to develop options for improved cellular pathology facility. The paper also highlights that that is a national priority, because as it was specifically referenced in the MAG report. Two health boards have been working closely over the last period of months to progress this work, supported by life cycle consulting, as referenced in the paper, with regular updates provided to the vice chairs of both health boards. And I'd like to thank Eleanor and Steve Spill, the vice chair of Swansea, for their support over the last few months. The paper from Life Cycle is included and presents three aspects to the decision making for us as a region. Specifically, they are the what, the where and the how for the cellular pathology service. So that is to in respect of the what, the options range from doing nothing or minimum to a new health board laboratory, or going to the full new regional cellular pathology laboratory. The second aspect is the location, and the paper sets out the work done to identify and assess site options. This has allowed us to narrow down the potential sites to 2, which are set out in the paper. And then the final aspect for us to consider is the options for the way in which the service is delivered, ranging from in-house to fully provided by an external pathology organisation. The paper has a number of recommendations within it for board to consider, specifically that we endorse the aspiration to develop a fully integrated regional cellular pathology service, so that's option 5 of that first set of options. Endorse the intention to develop a business case to determine the preferred site, and obviously progress the seeking capital to support that. And then finally acknowledge that from the work that we've done up to this point, it seems unlikely that a full service provider will be an option for cellular pathology service delivery. So we'll continue with an in-house model, at least for the purposes of progressing the plans from here. The final comment I'll just make is we did have a staff meeting on Monday, a staff briefing on Monday, to advise all members of staff on what is being presented today, and we've committed to continue that dialogue on a regular basis to keep all staff members up to date with the discussions, particularly given how long this has been going on over a number of years. So I'll stop.
Can I just ask how staff responded?
So there wasn't a great deal of discussion or debate or questions on it. I think the principles of a regional service are long established. So people who have been in the service for a number of years have been part of those conversations. I guess there's probably a sense of waiting to see if this will actually happen before giving an opinion, but certainly we were able to answer a few questions, and we'll keep that dialogue going.
Very good, thank you, Lee. Colleagues, questions? Yes, please, Anna.
Thanks, Chair. Lee, you referred to how long this has been going on. I mean, it has been going on for longer than almost any of us have been sitting around this table. Possibly not Phil, but but almost all the rest of us. I suppose my question may be one that is not reasonable to ask, really, but what is it that we can be confident about in this way forward that is different about the many other attempts that have been made in the past?
Yeah, thanks, Anna. Important question. So I think you'll see that the original plan started in one place and then became a very ambitious transformational plan, which contributed to the costs escalating. We also had inflationary cost pressures at the same time, which meant that the requirement, capital requirement for it was escalated to 135 million and were going up. So clearly that reached a point where it was not realistically deliverable from the Welsh Government capital provision. What we've now done is scale that down quite considerably to really focus on our more significant risk, which is the cellular pathology laboratories. And you'll see that we've had Welsh Government visits to those laboratories, including, in addition to that, the MAG feedback. And you'll see in the papers a letter that we've had from Welsh Government indicating their support for us trying to progress that at speed. So I think clearly we're not in a position to say that as a result of that it will happen, but all the indications are that Welsh Government are working with us and are taking a very pragmatic view in order to deal with the most significant risks that we've got. So we are certainly optimistic that we'll be able to take this forward, provided we can develop a workable solution quickly. Thank you.
Very helpful. This is good progress. We know that one of our concerns, a number of us have visited the pathology service in Glengwili, and it truly is, you know, a really poor working environment, laboratory environment. We have to resolve this as quickly as possible. In my view, it's poor of us not to give real momentum and thrust to developing this and taking it forward, because the circumstances under which those individuals are working is not acceptable by any standard. So I think this is great progress. I think it's really good. I think it's pragmatic, and thanks to Eleanor and Steve Spill, who I think have kind of offered their leadership and helped to provide some clarity and focus for the group in terms of taking forward. But actually, thanks to everybody involved in this process, because we don't get to this place without a lot of individuals doing some really important work. I feel we need to progress this as quickly as possible. So even though I'm hoping, Lee, that in terms of that business case, we are talking about a business case light approach to preparing for this in terms of Welsh Government support, so that we won't find ourselves having a conversation in 12 months' time that says we've now prepared the business case. I want us to be able to try and progress this as quickly as possible and to have worked to an outcome, and the outcome isn't the preparation of the business case, it isn't all the other consequent indications. The outcome is that we have an integrated pathology service working in an environment that absolutely supports them doing the best job they can as quickly as possible. So I'd quite like, even though the business case is still in need of preparation, I'd like a plan on exactly when we think we can deliver this by, back to those individuals being assured that this is the timescale we're working to, even if that has to flex in the future. One of the reasons, this is what we would want to happen. On that basis, let's look at the recommendations. So, colleagues, are we of the view that we would support option 5 to develop a fully integrated regional cellular pathology service? Great. Acknowledge the work that's been done on the early market assessment regarding of whether or not we could somehow develop a different business model around the provision of this service. I think the evidence is clear that's not going to operate at the current time. I do wonder, in relation to the fourth point, to support the continued exploration of external partnership opportunities, I'm not sure we should necessarily use our energy on that at the current time, having decided this is the way forward, and largely being of the view that it's going to be quite difficult for us to get any traction in that space.
The externals working on this really thought that was going to be difficult.
Yeah.
That market wasn't here for enough people to be interested to work with us. Yes.
Okay. Thank you, Eleanor. My view is that we support the intention to develop a business case. I think at the earliest possible convenience and stage, so we can progress this. And confirmed commitment to developing a single regional service pathology hosted by Swansea Bay as outlined in the Transformational Memorandum of Understanding, re-endorsed in March 25 by both boards. And then I think there's some practicalities, which is agreed to review any pathology leadership vacancies that emerge in either organisations. Feels to me this is an operational issue that perhaps Lisa, you and the team need to be, you and Tina need to be aware of and start thinking about in relation to those services in both boards. And agree to consider options to relieve pressure at Glengwili and implement a transitional plan to consolidate some services at Singleton at the current time that will just help alleviate the circumstances and conditions under which people are working. Is everybody comfortable with that? Thank you, colleagues. Let's endorse. Okay, shall we take a break for lunch and reconvene at 1:10?
Yep.
Thank you very much. Pnawn da pawb. Thank you for coming back. I was going to say so promptly, but we are running a little bit late at the moment. Nevertheless, we'll press on. Let us go to Equality, Diversity and Inclusion Task Force update. Lisa, I don't know if you're going to begin with this and then Anna kick in, or the other way around?
The other way around.
Okay,
I think,
fantastic. Great.
Thank you very much. And in the interest of time, I will try to be brief. As board members will recall, we had an agenda item on this very subject at our last board seminar, which was really helpful, and this report confirms, amongst other things, the actions that we agreed as priorities to move forward this really vital agenda for our organisation. So just to quickly draw attention to those on the second page, we agreed the priorities were to evidence the board's allyship to take a more assertive position on matters of equality, diversity and inclusion, to focus on engagement and co-production throughout our organisation through this idea of having a big conversation, and we are working behind the scenes to get that event, that starting event, off the ground, hopefully in November. And that will be quite a diverse collection of people, I'm hoping, who will come together to think through how we begin to snowball these conversations in the organisation. And then on a slightly drier but really important topic, to think about how we get smarter about using the data we already collect to generate more meaningful insights, to triangulate those insights, to think about intersectionality in the way that we are using our data, and I think potentially also to challenge us to think about how we more regularly review that data through the board, with the potential for it to be included, for example, in some IPAR reporting, although that is all up for grabs. I think if I might just in the context of that first priority around board allyship, Chair, if I might just take this opportunity really to acknowledge the increasing divisiveness and toxicity in the public discourse at the moment around matters relating to equality, diversity and inclusion, and that has consequences, I think, for all of us, for humanity itself, but I think particularly for those who are being targeted in parts of our country across the UK, and potentially even within our communities in West Wales. We know that many of the people who are targeted for this kind of vile abuse are working in the health service, and many people have left their home countries to come and work in our health service and to contribute in our public service, and that includes in our own organisation. And we simply couldn't function as an organisation or as a wider NHS without the contributions of people who find themselves being increasingly targeted for hatred and abuse in various different settings. And they nevertheless continue to care for our patients without prejudice. So I suppose a challenge for us as a board is to think in that allyship responsibility whether there is more that we might be doing to check in with our staff who may be feeling the effects of what is increasingly being normalised in the public narrative, and to think about how that might be affecting them in their day-to-day lives and even in their workplaces. So I think it's perhaps something, Lisa, that if we're not yet considering, it would be great if we could start thinking about whether we need something that is particularly for those staff who may be feeling most directly the consequences of the unpleasantness that's going on in a lot of the national narrative at the moment. Other than that, Lisa, I don't know if you want to add anything, but happy to take questions.
So I've got nothing directly to add to this. I could talk a little more about our equalities work when we have the paper later on in the People and OD Culture Committee update. Okay,
thank you, Lisa. Thank you, Anna. Colleagues, any thoughts or questions? Yes, please.
Yeah, yes, I also attend Anna's group as well, and I think when we had our last meeting there was some good engagement from the individuals there. I think as a board we need to be a bit uncomfortable with how we're performing in this particular area. I think Lisa's report later on will, where you see the disparity of grades of particular members of staff, the pay grades and opportunities for promotion and interview. I think we're on a journey as a health board. what I will say is that we've got the green shoots of really developing something. I think that leadership does come from the board, and that we need to encourage best practice, and we also need to be clear that we will not tolerate where behaviour and our values are not met as well as an organisation. I think what stood out for me, though, in terms of the paper as written, was the learning points, which was it is a complex agenda. Securing engagement is really, really important, and we also need to put our resources behind it as well, because it's not just money; it's also people's time to meet with others, time to really listen to them. I know that you, Chair and Chief Executive, you've met with particular groups of people, and I think that's really, really welcome. And I'd reach out to my IM and exec colleagues also to do the same as well, because I think it's a responsibility that comes with our leadership as an organisation. So that was my comment. I'd say, as Anne won't be too surprised for me to know, we need to be moving faster in this area rather than slower.
Thank you, Winston. Really helpful, and that's adding to the picture and the scene. Chantal.
Thank you, Chair. And I like the way the paper's been written, and of course I've been part and parcel of the group as well. And I think for me, just a plea for us to focus on culture within the organisation rather than just compliance with legislative measures, because I think, as Anna said, the narrative in the media at the moment is very toxic, and I think most of our ethnic staff certainly are feeling it. So it would be good for us to have a focus on culture rather than just saying we're meeting the needs of the legislation. Thank you.
Completely. Compliance is a minimum. It's not a maximum in terms of how we treat each other. Other thoughts or questions? So I would say this is a really important piece of work, and one that's is taking time to mature. I suppose that's how I would describe it. We haven't made the advances I hoped we would make in this, and not because I think it's not being led well, because I think it is. I think you're bringing commitment and clarity and direction to this work. I do worry that the organisation just doesn't. There's a complacency inside the organisation around these issues, which feeds through into the culture of the organisation. And I absolutely agree. I think what's happening externally is that the degree of social pathology and conflict in our society, and the binary nature of some of that conflict, is becoming increasingly more significant and more damaging and frankly more dangerous. And there is something about how we're not just here to include people and act in an inclusive way. We're here to protect our staff and to provide them with the support they need, sometimes to be able to manage that external environment and what happens. It matters to us that people are treated well outside of work as well as inside of work. It matters to us as individuals and as humans that that's as important to us as anything else that we do. So we do have to continue to put some thrust behind this agenda, because I have a sense that externally things are moving very fast, and we need to make sure the pace at which we are working to deliver and kind of build this agenda is at least comparable with what we see outside the organisation as well. But it's good work and it's well established, and I think it's growing well. I think I would want to see it ferment a bit more quickly. Okay? Great, thank you very much. Let's move to our next item, which is the Centre for Social Innovation. Ardiana.
Diolch, Kadri. Excuse me. So in front of you is the paper providing a bit of an outline and update on the development of the Centre for Social Innovation. We have embarked in a partnership with University of Wales, Trinity St David's, and formalised through a collaborative agreement in May 2025 an initiative to develop the Centre for Social Innovation, which is focused on being informed by our work through the social model for health and well-being in West Wales to identify solutions to our complex social challenges, not too unlike some of the issues that Anna, for instance, referred to in our equity and diversity issues. The paper outlines that the centre is, in the past 3 months since establishment, has focused on 2 main aims, and that is the establishment of the centre as a presence and the developing its brand to be recognised as a brand, as a centre with its own identity, and that in conjunction with our work on social model for health and steering group, to identify, to support, to carry out and to evaluate a number of core projects as are outlined in Appendix 2 in the paper, in a development of a 3-year plan for the centre. We've developed the governance around the centre, and we've developed the business plan with some initial scoping projects. Some of the key focus for identified in 25-26 financial year and then leading up to the 3-year plan focus on innovation and evaluation of the social work with our communities, on an immersive education and particularly focusing on awareness of a social model for health model. Guiding a coalition and advice through engaging with some of national and international thought leaders on how social solutions help and improve health and well-being in populations. Focus on prevention and early interventions, and we've got a set of core focus areas in that, being cardiovascular disease, diabetes with focus on overweight and obesity, respiratory health with a focus on some of the housing conditions and environmental conditions, and then the focus on the 2 ends of the life course for improved health and well-being of children and young people and healthy aging. There is a stream of work that we are developing on the workforce, developing skills on health improvement and prevention, and that through our volunteering, but also through development of a workforce that will be encompassed in community health and well-being workers. So I will ask the board members to note the progress with establishment and development of the Centre for Social Innovation, and to take assurance that the work and projects are progressing and will contribute to understanding, adoption and progression of the social model for health work in our region. Diolch.
Thank you, Adriana. A really important piece of work. Hywel.
Diolch, Cadeirydd. Thank you, Adriana, for the report. Firstly, just want to declare 2 interests, if I may, on this item, which I didn't do at the start. Apologies. On page 2 of the report, it notes the work which the team is already doing on an evaluation of the Carmarthenshire Living Well Centre, which is a project I'm leading on with my Planet hat on, and also in terms of University of Wales. I'm on the council of the University of Wales.
This is the project based at St David's Park?
Yep, that's right, yes.
Great, okay.
So, again, working with the team here at the centre, they're undertaking a full evaluation of the Living Well Centre. And just to support in terms of what we've just heard, it's really kind of going down into the granular detail, and the work of the team, certainly amongst the 20 organisations which I'm kind of coordinating at the Living Well Centre, have found the work invaluable in terms of the insight to look at the wider determinants of kind of prevention and that social model of health within our communities. And certainly it's something that we will continue to work with the team as we go into the 2nd phase of the evaluation now later this year.
Diolch yn fawr.
Great, okay, thank you. Michael.
Yeah, can I say, I welcome this development initiative. Who is, it's an arm's length body, isn't it?
It is.
Yeah, so is there, who is it from the health board? I know it's like co-director health or something. Is that a particular individual, or how does that work in that we man it? Or?
So it's a collaborative agreement, excuse me. So it's an arm-length body. We are in collaboration with University of Wales, Trinity St David's. We've got a special advisor that has been working with the Health Board for many years, particularly focusing on the social model for health work, who is one of the co-leads of the centre. As you would have seen, 0.2 work time equivalent from the Health Board. And there is another one from University of Wales, Trinity St David's.
So we've got a kind of we got a voice at the high level there. That's important. It's good.
Yes, that is in sort of the operations, and then as I described the governance around it, we've got the executive group, which includes myself and an executive from Trinity St David's. Hugh Thomas will be sitting in that sort of steering group as well, and then there is the operational steering group that has got members of Health Board, Trinity St David's, so the governance is a collaboration as well.
Chantal.
Thank you, Chair. I think I may have missed something in between, and so what I'm not sure about, what are the defined outcomes that we're seeking as part and parcel of establishing this Centre for Social Innovation? Or are we thinking about it in terms of an organic type of centre whereby we take on projects and we deal with those projects as they come? But I think at some point we will need to see what the outcomes and what the impact is, given that obviously I'm assuming that we have to put funding towards that in order for us to have this collaborative approach with Trinity St David's.
Yeah, and it's a good point, because we want to, anything that we initiate, there is a view that we will improve outcomes of our the health and well-being of our population. So that is the ultimate aim of developing the centre. But the centre is developed with the view that as a health board, as I sort of opened the item, the health problems of our population are now much more complex, defined by our commercial and environmental factors than directly the health causing, as in traditional sense and conventional sense, factors. And therefore the solutions that we know that we implement are much more of a medical approach and medical framework, including sort of governance with starting innovation for health services. We haven't got that expertise and a framework to be more innovative in the social dimension of impact on health. And that's why the centre will enable us as a health board to be removed directly from the health board to explore and bring those innovation that will, as I said, challenges that we identify through the work of Social Model for Health. And as a health board, they'll take those challenges and bring expertise, thought leaders to help us through evaluation and embedment provide some of the solutions. So the outcomes would not be short term in 6 months, but for instance, these 3 key projects that I said that have been identified through the stakeholders for this year and the 3-year plan, we should see improvements. For instance, in CVD, respiratory, children, young people, we're focusing on neurodivergence elements of the children, young people, and the aging well. So I think that's the aim, and those are the sort of the outcomes we should be seeing.
Okay, thank you very much.
Winston, and then I'll come to Phil.
Yeah, a couple of strands here. So the first thing is, so which committee would you see this reported into in terms of its value and its outcome? That was the first question. The second question was, how does it link with value-based healthcare and patient-related outcome measures? How do we marry those two together? And thirdly, we have a digital innovation committee where we pick up on research and innovation. And I wondered how that kind of links in with that, because I see the potential for it to go in different directions. So it'd be good if you could clarify that.
Thank you, Winston. Good question. So committee, it's very clear. So it comes, as I said, it's sort of an arm of our work on social model for health and well-being. Therefore, we report through this strategy and planning committee. And with value-based healthcare, yes, our specific team that are dedicated to value-based healthcare are very much part of that operational governance and have been involved all through and will continue to be involved. Whether we apply patient-reported outcomes or patient-reported experience or population-reported, I think that's part of the challenge that the centre should help us. Are those valid measurements to focus on, or should we have some modified measurements that report experience and outcome of the population rather than patients?
Thanks very much. Thank
So
you.
confirmation there that it will kind of report into strategy and planning,
Strategy
for
planning
which you'll be responsible as the chair.
Yeah, indeed. Thank you, Chair.
Okay. Very good. Okay, thank you, and good questions. Yeah. Phil.
Yeah, thank you, Diolch Cadeirydd. I suppose perhaps I've come at it in a slightly different angle, I suppose. So we know that healthcare alone only contributes to about 15% of health, population health and well-being. And I suppose we spend over 50% of the Welsh Government budget on the NHS. So there is a paradox there. I don't know whether that's the right word, but there's at least an issue. I suppose so the whole point of the social model of health and well-being was that we have an extremely medicalised model of health and well-being. We must do if we're spending 50% of the budget on the NHS, and we know that there's all these other things that contribute much more to population health and well-being. The other point is that whilst we are a health board, we don't control all of the levers of the things that contribute even more to population health and well-being. In fact, indeed, public bodies don't on their own control all of that. In fact, it's within communities that health and well-being is created. And I suppose when we've talked in the past about our work around the social model of health and well-being, we felt that we needed to provide some leadership in this, because if we needed to move away from a medical model of health and well-being, a predominant medical model of health and well-being, then we've got as much to do to change as others, and we felt that we should lead that. Now, one of the challenges with the social model of health and well-being, though it became apparent, was that holding it within the health boards started to become a challenge, really, and it's not and slightly odd for other public sector bodies like our councils and police and other sectors, and also communities. And there was even a question, should the NHS be involving itself in this? Now, personally, as you know, I'm a great proponent of it, and I feel we should be. I think we should be showing leadership in that area, because if we don't change, we will never see us move to a more social model of health and well-being. But we did feel we needed to move it outside the health board's kind of direct remit. We felt it should be sitting somewhere else. We spoke to all three universities that were on our patch, and University of Wales, Trinity St David's did come forward. So there was equal opportunities, but the other universities are engaged in this activity as well. It's just that it's cited in UWTSD. And in terms of the outcomes, you see, it probably doesn't. The issue with value-based healthcare is that this isn't so much about healthcare. It's much more about health creation, prevention, promotion of health and well-being. And in terms of the kind of measurements that we would want to look at, well, we're going to need to create those measurements. Part of our work on social model of health and well-being found that actually the measurements that we have, it's not quite as mechanistic as you do this, and therefore this happens within a community. So part of the ask of that Centre for Social Innovation is to help us create that new way of measuring value in these activities. I think the collaboration agreement is more important than us having actual staff within the centre. So, you know, we've been at it for about a year. We need to keep reviewing that collaboration agreement, and we do need to keep a close eye on it. So I'm really pleased to see it's come here today, but I just wanted to give that additional context. This is a really creative edge, creative space. We definitely need the advice of partners and our communities and our third sector in this, which is why, and you know, having Yuan's advice on this is essential, I think, for our success.
So just to pull this, so did you want to come back?
Yes, just to add something, if that's right, and thank you very much, Phil, for properly contextualizing that, but it just reminded me that part of your question, Chantal, maybe I did not kind of elaborate and address, and that is, and it relates to Michael's also question. So the funding, the concept is that, yes, the centre, as it develops, establishes and defines itself, the brand and the identity, will attract funding, just like any other, for instance, academic institution, be that for bids for developing innovation, research, evaluation, be that from enabling mechanisms that pool joint funds. For instance, like we're working on social model, on asset-based community development and other elements. Thank you.
So I think all of this has been very helpful. I mean, it's starting relatively small. Despite that, we are looking for things large from it. Yeah. So, and that's the nature of our aspiration. We want this to work really well. What we have to avoid is the danger that we face, or the risk we face, is that we'll just put it over there, and we'll just carry on doing exactly what we've been doing before. And occasionally we'll refer to it, and we'll take pride in some of the things it's achieving, but actually its ability to fundamentally shift the whole question about how health is delivered, or how it's received, or where the responsibility for health lies, will be difficult to establish. So I suppose my proposition is that we can't just leave it over there, or just rely on strategy and planning to occasionally receive an update. We've got to think about how we actively, as a board, bring support to this, other than just helping to fund an initiative that's based inside the university. If we really want this to work, it has to permeate everything we do, everything we think about, everything we measure, everything we understand about the way in which we deliver our services. So perhaps what needs to come back at some point is, this is how the Health Board needs to embrace and engage with this idea, as opposed to just think we've parked it over there.
So that's very helpful, Chair, and very welcomed. But I'll just also remind that exactly in that fashion is that we have signed up, as a board, we've signed to the principles of social model, which embed all of those 6 principles with communities, with voluntary sector, focus on prevention, not to, but with innovation, prevention, and we are reflecting those probably not as explicitly as we can in the way that our entirety of the board, not the board, but the health board works, and whether we address those principles of the social model for health with every initiative, every service development, everything that we do in improving the health of our population, I think we can strengthen that, definitely.
Right. Okay. So it would be good if we came back to this board, as opposed to discharge it, at some point come back to this board, so we are regularly engaged in the conversation about it. Yeah. And rather than just an update, challenge us as a board to some of the things that are emerging from it.
Yeah, will do.
Great. Okay. Let us. So we take assurance from the project. It's a great idea, and we're deeply ambitious in terms of what we hope it will achieve. Let us move to report of the Audit and Risk Assurance Committee. Rodri.
Diolch yn fawr Cadeirydd, a hefyd gallai ddiolch i Winston am cymryd yr arweinau yn cadeirio cyfarfod diwetha. Can I thank you, Winston, for kind of chairing the last meeting. I've looked back at it. It was a very good meeting, kind of very good scrutiny. It was quite fiery at times as well, but that's good. And I've asked Winston if he could just give me just the update of those 3 relevant parts that we discussed earlier. So if you don't mind, I'll pass it on to Winston.
Yeah, I
Fantastic.
think it's whilst the cat's away, the mice will play. Because both Rodri and Joe wasn't present at the meeting. So, but yeah, I think the update report and the advising the board really just captures it, really. Some concern about the new operating structure. I think the Chief Exec's report earlier in this meeting has kind of covered that. The areas of concern was two limited assurance reports, both related to sickness. One was sickness management and the other one related to nurse management, but they're all essentially about the same thing, which was compliance with the All Wales policy on sickness absence management. And where it got a bit, where we had a good debate, I'm looking at the Vice Chair about this as well, was a particular challenge of the auditors about their sampling size and whether they'd taken the right sample over the right period of time. So it wasn't just the Vice Chair, it was also the Deputy Chief Exec waded in as well. So the result of that is that the audit will be redone again. We weren't happy that there was a limited assurance report on sickness absence management and nurse management, and hopefully that will give us some greater assurance in that degree. But it has to be said, there's going to be an element of truth to the fact that there will be areas of the organisation that isn't compliant with the All Wales policy, and that we can do better. And if you look at the performance reports earlier today, I think our sickness rate is about 6.8 or 6.5%. If we got better than that, then it would have a significant impact on our financial performance, as an example. So it's an area worth pursuing. In relation to the report itself, we noted the escalation update, and I think we covered the areas that you'd expect us to cover as an audit committee, to be honest. I don't think I've got anything else to add apart from the fact that we did cover two policies, which is in the board papers, the risk management framework and the risk management strategy, which are attached to ratify as well. We also reviewed the fraud and corruption bribery policy as well at the audit committee. Happy to take any questions.
I just want, from a governance perspective, even though the internal auditors will review those thickness reports, the limited insurance does stand. So we have a significant number of limited internal audits already this year, which I know the Chair of RX is going to pick up at the next meeting, because it is likely it will affect the year-end position where we are currently. So even though they'll redo it, the rating stands.
Thanks. Okay, sobering. Sobering. I mean, we need to, well, first of all, there is something about accepting the recommendations of those, be them limited, as best as possible, accepting the recommendations and delivering the recommendations.
We did accept the recommendations, but it wasn't an easy acceptance of the recommendations, if you like.
Okay. Sharon, did you want to say anything?
I think Winston's covered it really. I think we have made significant, from a nursing management perspective, there's been significant progress in terms of rostering practice and scrutiny, but the sickness element needed more work, so we had two limited assurance for two separate audits for the same item. Yeah.
Okay.
Yeah.
Okay, fine. Thank you, Winston. Very, very helpful. Okay, so we're asked to ratify the risk management. Well, actually, the next stage is the risk management framework, isn't it? Which item 17.1, which I think you'll pick up. So note the items on the committee we're being advised about and take assurance on the items that the committee is providing assurance on, which I think is fine. Okay. 17.1, Joe.
Yes, I'll be brief on this, Chair, because the Audit Committee did scrutinise this in detail. It's also been out throughout the whole organisation for comment, which any feedback's been included and has been shared with the board. So they're both for approval, and I wasn't planning to go into any further detail unless there's any questions, Chair.
Okay. Are we happy to approve the risk management framework and the strategy? Yep. Okay. Let's agree that. Let's move to report to the Quality, Safety and Experience Committee. Anna.
Thank you, Chair. So the report stands. This is our meeting that happened in August. Just to pick out a couple of things, really. The advise item relates to our sonography services in midwifery. We had a really helpful presentation about this. This is a risk that we've been tracking through QSEC for some time now, and we've been trying to get under the skin of what the workforce shortfalls in sonography have meant for our patients. So we were able to take a really good item on that, and what we were alerted to was that actually the long-term solutions to this issue, this sonography issue, will require a more strategic workforce review, and that work is beginning now, and there is a timescale, I think, back to March next year for something to come back to the exec team initially, and then potentially the board as well. And in the meantime, work continues to mitigate the risks, but there are nevertheless residual risks associated with the shortfalls in midwife sonography, in sonography for pregnant people, which is being covered to some extent by specialist training for midwives. So that was really helpful to be able to take that item, and it feels as if we finally got to the bottom of what all that is about, and we can expect to hear more in due course. I think I will just, you can see the broad range of issues we deal with in QSEC, as I know all committees do. I would just like to sort of pick out the update on a new working group that has been formed for the Learning Disabilities and Epilepsy Service. Members with a long enough organisational memory will know that this is a long-standing issue dating back to 2021 with a lot of history over the last 4 years, but I think the committee was able to see that this new working group has been convened with a very clear scope and pace and a commitment to work across internal boundaries, which perhaps has been part of the issue, at least historically, and a clear expectation on the committee's part that this will start to produce some really significant results for the patients and their families who are affected by the service changes that have been underway and over recent years. Can I also just give the board a verbal update on an extraordinary meeting that we held in September? Are we still in September? Yes, it is still this month. And the reason that we held this extra meeting, and we have another extra meeting scheduled for November, is that I particularly wanted to be keen that when the board comes to consider the details and the feedback from the CSP consultation process, that it's in a position to ask our committee what is its assessment of the assurance that we have around each of the 9 pathways that are subject to the CSP process at the moment. And while those pathways move in and out of QSEC's agenda in the natural sort of flow through the work plan, we wanted to make a sort of a concerted effort to make sure we were bang up to date in our assurance of those 9 pathways. So in this first extraordinary meeting, we considered the first 3 of those. We are considering 3 more in our normal October meeting, and then we'll do the remaining 3 in November. So on this occasion, on the 15th of September, we considered critical care, emergency general surgery and stroke services. I think in terms of specific issues, we picked up one around the way in which the critical care pathway is working currently. Mark and Andrew are working through some issues around the application of the standard operating procedure to ensure that it continues to be clinically aligned and useful from a quality and safety point of view. That work is ongoing, and we'll continue to track that. But I think if I were just to pick out a couple of themes really that I think were relevant across all 3 of these pathways, and we won't be surprised to hear this, but I think looking at them together, it was really very obvious that the critical mass we need to sustain services in a confident and long-term manner cannot be achieved in the decentralised fashion in which we currently do it. And there are consequences in terms of workforce fragility, and particularly around medical rotas, and the unattractiveness and potentially lack of safety involved in very demanding on-call arrangements, and also in our infrastructure and the capital investment that would be required to move some of these services forward. So all of those things contribute to an impact upon quality and safety, which is really inescapable, despite the best efforts of every person who works in these pathways. And I think while in some ways we shouldn't be surprised to hear any of that, it is nevertheless useful to just check back in on that and remind ourselves the reason we go through these processes, why the CSP is so important, is because we cannot continue as we are. And that quality, safety and experience assurance scrutiny really drove that home very clearly in that additional meeting. So there isn't a written report for that today because we're just out of sync with board timings, but we will in due course provide that, what I've just fed back now, and updated in a written form.
So somehow, Owenna, I'm just thinking about, it feels to me that's pertinent when we come to think about all the evidence and information we're receiving in relation to the clinical service plan consultation. We do need to consider that evidence as well, because I think that's profoundly important.
Point of accuracy as well.
Yeah.
It's just sorry, Anna. So we have got a record of that. It was minuted because it's a formal meeting, so we can share that with Alwena and it'll be on the website. They're just on the first report, Chair, just to flag a point of accuracy in relation to the section 136 that was due to be at this board. However, there's still further work needed on some of those options because there's additional information come to light. So we're hoping to bring you that back at the next board meeting.
Okay, great. Thank you, Joe. Fine, okay, in the interest of time, I'm going to move us on. So note the items that you brought to our attention, Anna, and to take assurance on the items that you provided assurance for. Great, okay. Can we return to the report of the Finance and Performance Committee? Michael.
Yes, thank you, Chair. Well, much of this you've already discussed this morning. So you'll see that at our meeting at the end of August, there was a lot of discussion about what we call the savings gap. There was also, so there was an alert on that, but that's something you would have, so I was stuck on the M4 at the time, but you would have discussed this, I'm sure, in great depth this morning. Similarly, there was advice on some performance concerns, and I think again those were matters which again should be well known to the board. So that really, I say, much of what we discussed would have been covered earlier this morning. We also had a special meeting on the 15th of September, which again was looking at the financial choices issue, which again would have been one of your items of discussion this morning. So a fair bit of scrutiny in advance of today done by the committee, which I trust was helpful and informed the discussions this morning. Thank you.
Great. You were obviously clearly unavoidably delayed this morning. We did have a healthy kind of exploration of the issues this morning. That's very true. Colleagues, any further questions in relation to what Michael's just said? Yes,
not
please,
so much in
Mr.
relation to Michael, but taking the QSEC reports and this one together, there's a service that comes across in both of these reports, and that's ophthalmology. So ophthalmology comes up in the QSEC report in relation to the staffing and the ability, and ophthalmology also comes up in this report as well in relation to the plans towards the ophthalmology recovery waiting times, and it also comes up in the I think it's the outsourcing of the ophthalmology service. So that's a concern to me that it comes up in two separate committees in the way it has. So I don't think there's an easy answer to it, Chair. But I think it's something that we ought to just note that it's coming through from more than one committee to the board.
Yes, you're absolutely right to raise that, Winston. Hugh.
Yeah, Chair, not a surprise to me, given we know that there are a number of challenges within that service in terms of the performance that we're seeing or the outcomes that we're seeing. But actually, just more generally, we do tend to see that there are issues that crop up in a number of committees, and that's probably right because in many ways finance is the consequence of other challenges that we're facing. So it's not a particular surprise. I guess there may well be a need for us to reflect on how we bring some of the common themes together so that we can address them in a coherent way.
Yeah, I'd just say that it's subsumed within planned, in the planned clinical care group, isn't it? But it's how specific it's come up, and it must be one of our fragile services, ophthalmology, and therefore as a board we have to be thinking about, well, are we doing enough to ensure up the safety of the service? One thing is, and its short-term performance and what that impact may have on those people and patients affected by ophthalmology.
Good challenge, Winston. Good challenge. Adrian, did you want to say anything?
Just on that part, and looking back to the QSEC kind of report, risk 664, are we actively looking for ophthalmologists as in consultants then? Is it an advert that's consistently out there? I'm just thinking because I had someone that spoke to me and he said there's nothing from a Hywel Dda point of view out there in whatever kind of
There
areas
may be
you
not
advertise.
at the moment. We have repeatedly and looked around the world for ophthalmologists. We have been successful, but there may not be an advert out at the moment. Advertising continually is not the right thing to do. That obviously sends a message that you're probably.
We just can't appoint and nobody wants to work for us.
So whilst it may look that you're not then trying, we are trying.
I'll pass that message on.
Yeah, and actually,
unless they're an ophthalmologist and they want to come and work for us.
Well, there is an argument that if people are interested in coming to work for us, even if they don't see the advert, they should be having a conversation with Mark or with Lisa. So, to be proactive in that space, because we might not be advertising it, we'll always be interested in talking to people who want to come and work for Hywel Dda. Great, Phil.
Yeah, I mean, one of the things you were making me think of, Winston, is about value, really, the sort of connection between outcomes and resource utilisation. And we know that we've got challenges around the ophthalmology workforce. Mind you, we're putting in a huge amount of work to be pushing the boundaries on where we could be creative. So I suppose our optometrists, I know Jill would say and has said before around this table, we have more engagement perhaps with our optometry colleagues than other health boards would do, but partly out of necessity, but partly it's been the innovation of our optometrists. Indeed, one of them is, I know, is the whole team have been nominated for an award because it's all over LinkedIn, happen to have seen this, so hopefully they're successful. But in terms of we can't be completely reliant on our ophthalmology workforce. I think the other point is that I think more and more we see ophthalmology as one of those specialties that we need to think of across a region. And we are working, it is one of those services that we work very closely with Swansea Bay on, and we get updates through the Regional Joint Committee for those of you who sit on that. So because actually our on-call rota, for example, it's difficult for us really to provide a separate on-call rota. So it's that sort of thing where we do need to work with Swansea Bay and also seek opportunities with them to make best use of our total ophthalmology resource and total sort of theatre resource to provide the care for the whole 800,000 to 900,000 people. So we are, I think the fact that you're seeing it isn't that surprising, because we're doing all of this work both in community and on the specialist side to try and improve the value.
Thank you.
Great, okay. If I can move us then to recommendations. So approve the award of a histopathology managed service contract with Leica Microsystems UK Limited. Approve the award of an outsourcing of ophthalmology services, mobile theatres, stage 4 cataracts, contract to Spa Medica. Approve the renewal of the National Care Homes Framework. Agreement should no further alternative be available. Ratify the terms of reference.
Jay, can I just come in on the National Care Home Framework, because there are some discussions going on nationally. Things have moved on a little bit since the paper was produced. So what I will do is, if we can approve that pending confirmation of national agreement, and I'll bring something back in a future procurement report just to confirm.
Great, okay.
Thank you.
Point taken. Respond to the item that the committee is alerting us to, which I think we did this morning, largely, and take assurance from the items the committee is providing assurance on. If everybody's comfortable with that, let's move to procurement report. Hugh.
I think we've just covered
Jay,
that.
you've just gone through it.
That's it. That's everything. Let's move then to report to Strategy and Planning Committee. Winston.
That's me, yes. So nothing to alert the board to. Just want to touch briefly on areas of importance. Progress made in the regional collaborative working arrangements, and in fact Jill and I met with the chair of RPG, I've forgotten her name, temporarily, Jill.
Hazel.
Sorry?
Hazel Lloyd.
That's right, and we had just by way of introduction, and it was really good meeting, wasn't it? Good to got across committee things and just say hello. This is who I am, and her background and stuff. That was good. There's a lot of things that they would like to do in conjunction with the health board. They welcome our collaboration with the public on our CSP and other things, our strategy refresh. So I think it'll be really interesting when Welsh Government reissue what they would like them to do. They want to make sure that local initiatives as well as national initiatives are implemented. Noted that we had a Chair's action meeting on the same-day emergency at Glangwili Hospital. I think that's attached in the papers to the board, which we can consider. But what I will say about that action meeting was it's very good to hear firsthand the enthusiasm of our staff around this change, what impact that's going to have in terms of the layout to the service at Glangwili Hospital, and that they're keen to make that happen. The other thing I'm going to pick out from this report is we continue to receive capital funding from Welsh Government, which is rare these days. So we've received another, I think it's £3 million in relation to radiology equipment and ultrasound, which I think is a welcome change. The other thing we covered at the SPC committee was in relation to our winter plans, which again the board will consider in its winter vaccination programme, which the board will consider shortly. So that's all I wish to say at this point. Happy to take any questions.
Great. Thank you, Winston. Could we come to Lee for just an update on the Glangwili Hospital front door business case?
Thank you. Thank you, Chair. Thank you, Chair. So this is a piece of work that's been going on for a number of months. I think everyone will be aware of some of the challenges we've faced in Glangwili, and we've obviously had GIRF report and MAG, Ministerial Advisory Group visits to Glangwili previously. Welsh Government officers visited Glangwili earlier in the year, and along with other sites in Wales, and we're seeking proposals to improve the front door provision through some capital availability this year. So as a result of that, operational clinical teams have been working on what the exact proposal could be to support that. As Winston mentioned, we took this paper through a Chair's action meeting. We had a good discussion about it. This is the preferred proposal that has now come forward. We are up against it time-wise because the capital availability is only for this year, but we think this is a good option to improve Priory Day facility in a way that could alleviate some of the pressures within the emergency department. So we're looking for board support for this case for us to submit to Welsh Government immediately following board. Thank you.
So can I ask, we're just crossing two issues here. So let's just take the front door business case first, and then we'll come back to agreeing the broader SP committee recommendations. So are we happy to approve and continue the submission of the business case to Welsh Government, bearing in mind short time span on this? You and I, Phil, will need to sign this off. Am I right?
Yeah, sorry, Chair. So what we were looking at, I think we've got a paper ahead as well. So I think when we get to the recommendations where we've got approved the award of the works to John Weaver, I think the recommendation, Chair, when we met was to include in there, rather than leaving it a bit loose in terms of approval and report it back to the next board, that we would add into there that would be delegated to yourself and the Chief Executive to sign that off on behalf of the board, so that, as Lee said, time is an imperative on this. So once we got those final costs, if it is over £1 million, that yourself and the Chief Executive would sign that off on behalf of the board if the board is happy to delegate that to you.
Is the board happy to delegate that to the Chief Executive and myself? Great, okay. Feels to me that's a really positive step forward. It's going to have a relatively, well, £1 million is a lot of money to spend on a change, but the value of it could be well exceeded in terms of the benefit to the hospital, so that's great. Thank you, Lee, very helpful. Let's go back to just the issue around F&P. Let me get back to my papers. So just note the items the committee is advising us of and to take assurance from the items the committee is providing assurance on. Everybody comfortable with that? Great, okay.
Just need to go back to winter respiratory with Ardiana then.
So Ardiana, can you take us through winter respiratory vaccination programme, please?
Yes, delighted to. Thank you very much. So I'm very pleased to present the paper on our plans for delivering the autumn-winter seasonal immunisation programmes for 25-26. That's influenza, flu vaccination, COVID vaccination. The paper, which I take as read, lays out our plans in line with Welsh Government service specifications for delivering these important vaccination programmes, and it lays out our ambitions for improving uptake of both flu and COVID vaccinations. We're working primarily in support of primary care in their delivery of the core eligible groups for flu vaccination, and that is a very extensive eligible group with 2 and 3 year olds, all 65 and above, 6 months to 65, at clinical risk, carers, household contacts, pregnant women, healthcare workers, poultry workers, and our healthcare workers. So that is the core business, if you like, of primary care, with individual call, recall, patient information for delivering the flu program, and they will be delivering COVID vaccination as an option of those patients asking for COVID vaccination. Our health board, health protection immunisation team will be delivering core and invitation-based COVID vaccination, and will be administering flu vaccination as alongside COVID if those patients ask for. Our school immunisation nurses will be delivering the flu vaccination to all school-aged children. And our health protection service will also be delivering alongside our general practice and community pharmacies. In nurseries, they will be delivering to 2 and 3 year olds, learning from the pilots of the last year and from programmes elsewhere in Wales. I would like to highlight to the board that I'll make a correction in the paper following a meeting and conversation that we've had with our local medical council, that our engagement for informing the local medical council in the delivery of nursery-based flu vaccination should have been better this year. That was largely due to the timelines of our board governance, and we've had that correction and will rectify with the local medical council going forward. The plan for improving vaccination, you'll see there in the paper, is very much centred around more tailored and behavioural insight informed letters and text messages to our eligible population. It's very much centred in a strengthened and improved communication plans. We are targeting proactively through our social media, our areas of low uptake of both flu and COVID last year. And we have increased drop-up opportunities through our community services. We'll have pop-up clinics and a very strengthened and improved access to delivering for our own healthcare workers. So we've expanded that delivery this year, all with the hope that at the end of the season we will have much improved from last year uptake of these two vaccination rates. We have set ourselves an ambition to improve by 3% compared to last year uptake of all eligible groups. And with that, I'll just ask the board to note the plan, to take assurance that we have a delivery plan, to note the work underway to mitigate the risks of the programme, and to take assurance that we have control measures in place through recognition of the key enablers and identified actions to improve uptake. Diolch yn fawr.
Thank you very much. Bill.
So when I visited the inspirational Dr. Joe Cudd, who's a headmaster at School Penrose in Llanelli, I saw the team in action. I saw the nurses in action vaccinating all the children, and they all looked like they were enjoying it. And they said they were going to get through 190 that day and well over 30,000. Towards 40,000 over the time period this season. So these are significant numbers. Yeah. So I was really impressed with the way the team were going about that, and also the engagement of schools. But I would say we do have low vaccination rates relatively in this community amongst our staff and amongst our public. And there's no doubt that then has a knock-on effect to the amount of GP appointments that we have over the winter, the amount of hospital admissions, hospital attendances, people in our beds, and also staff sickness over the winter period. It has a significant knock-on effect, the fact that we have low rates. So I suppose I'm urging all of us, I'm urging all of our staff and our public to really engage with this vaccination programme. It will keep us safe, it will keep your family safe. So all the support we can give to Ardiana, her team, and all of our GPs to get our vaccination rates up, it will keep us safer.
Very helpful.
Thank you very much, Phil, for that. And I would just like to emphasise that, as you say, historically, for our population, we haven't achieved the ambitious and required uptake rates. However, with our school-based delivery, we are comparatively in Wales one of the best health boards, which that is a very clear indicator that our population, when the programme is well delivered in an accessible way that does not require individuals to take extended actions to attend for clinics, we have done well. So we are one of the best for the school-based delivery. And the nursery delivery, which we've started this week, it shows that in the nurseries where it's taken a lot of efforts, and I commend our team, my team in health protection, for engaging with nurseries to actually get their agreement to deliver the programs. In some nurseries that we've already delivered, we've achieved over 70% of the children aged 2 and 3 year old to actually be vaccinated. And we have the evidence, our own evidence, that with only 7 children vaccinated, we avoid 1 GP appointment, which is a very significant return on investment.
Thank you, Ardiana. That's very helpful. I'm sorry we need to press on, but your point is well made, and something that we should continue to be vigilant about and work towards. Very helpful. Okay, so let's take assurance from the control measures in place, and actually thank everybody involved in the process, because it seems everybody's working exceptionally hard to do that, and the risks currently in place to mitigate the programme delivery, poor programme delivery in this case. Great. Okay, let's move to report to the People, Organisational Development and Culture Committee. Eleanor.
There were no advisors. I'm going to take the paper as read. There's three points I'd just like to make. 2 of which we've discussed is around the clinical care group. The committee has concerns about how long it is taking to implement it. The Chief Operating Officer has promised to bring a paper back to the next board with a timeline in it, because it was reported to us that it could take a further 9 months to implement it, despite it having been started in April. And the other points, just to note that there's work going on, but it'll come back to board, around the pay gap and the strategic equality plan and the pay gap. I really have asked that we see what more can be done in that space, and we can link across to the EDI group on that. And finally, we had a discussion around the culture overview report and acknowledging the challenges around staff morale and resilience and tolerance for change at the moment. And we'll take another look at that as a committee in February.
Thank you, Eleanor. Any questions or comments? No? Okay, we'll take the strategic equality plan separately because I think Lisa's going to pick that up now. But just to note the items that you've raised, and you're advising us of, and to take assurance from the information that you've provided assurance on. Thank you. Press ahead.
Okay, yes, thank you. So the Strategic Equality Plan, we have a requirement every year to produce this strategy and give an update in terms of our action. So we have produced a detailed workforce report that supports the annual plan, and we've also produced 3 pay gap reports. So gender and ethnicity are statutory requirements. We also produce our disability pay gap report as well. Each of these documents have been produced and discussed in detail at the People and OD Culture Committee, and we've provided the executive summary here today. The papers are available on the internet, so if anyone wants to go into the detail of each of those reports, they are available. We are really pleased to be able to report the positive progress. However, a great experience isn't being received by all of our staff, and that's reflected in the insights papers that are also within the report. So there is much more that we need to do. And if you particularly look at page 1292, which talks about our staff survey, you will see the arrows on the left where we have green. These are when we look at the experiences of our staff in the staff survey of last year compared to the year before. There's quite a significant improvement in how people are treated within our organisation. However, the ones on the right are how we compare to the rest of Wales. So when we look at our outcomes compared to the All Wales position, we're showing a 10% difference in positive experience. So that is really not good enough. And the work that we're doing with Anna now is around how we drive this and start to make significant improvements. Our next staff survey will be launched very shortly. It'll be interesting to see what people say. So we're seeing the green shoots that Winston referred to on the left, but evident that we have got much more to do. So I'm happy to take any questions.
Thank you. Well, this partly plays through into the work that Anna's doing. I suppose I might be misplaced in this, but I sometimes have a sense that we're a bit passive, Lisa, you know, in terms of the agency we need to fundamentally bring about the changes we need to. These changes are not going to happen easily. And we can't rely on the goodwill or education or generally that kind of incremental approach to improving change. We absolutely need to drive this. Yeah. It's, you know, as I said last year, at exactly the same time, it is shameful when we see this information and realise we are part of an organisation where people get treated badly. It's just not, it's, you know, because of the colour of their skin or because of some other level of difference or vulnerability. It's not acceptable.
Absolutely. Can I just add as well, we are looking at the work plan for the workforce and OD team, which includes our equality diversity team, and we are looking at how do we add that pace and urgency and look to disrupt the system. So we'll report more of that through the People and OD committee.
I think that's a great ambition. I do think we need to be more disruptive. We need to have more thrust. We need to be able to operate in positively in conflictual environments, all kinds of things. Yeah, okay. Okay, any questions or thoughts? Can we approve the Strategic Equality Plan annual report? I'm presuming yes. Okay. Thank you, Lisa. And then go back to the previous item, just to confirm, Eleanor, that we've noted, obviously, I might have already said this, the advisory points, or I have. Okay, great. Okay, let's move on to report of the Health and Safety Committee. Anne.
Thank you, Chair. I'd just like to advise the committee, the Health and Safety Committee, through a staff story it's been identified there was a lack of adequate personal protective equipment for for porters who were required to respond to serious incidents. Mitigation options are being explored, including the provision of additional PP in short term and the potential introduction of dedicated security personnel as a longer term solution. The rest of the committee we took assurance on, so just note the items the committee is advising them and take assurance on the items the committee has provided assurance on.
Thank you, Anne. Are we all happy to do that? Great, okay. Fine, let's move to the report of the Charitable Funds Committee.
Okay, thank you, Chair. This is today's mystery item because there's no paper. Yeah, apologies, there is no written paper for you to consider because the meeting was only held 9 days ago. So kind of colleagues in committee services have been very busy trying to get papers all assembled. Just to kind of run through in terms of the meeting, in terms of what we went through the performance and there were no issues to raise there. We were assured in terms of performance against risks and in terms of the controls which were in place and working. We had 3 items for approval in terms of charitable funds expenditure. The first of which was around the development of therapeutic gardens at Prince Philip Hospital, which I know we will come up a little bit later on as well. 2 options were presented to us, and we'll again go through that in more detail later on and within the meeting. The second item which came to us was the Heads Up Initiative, Cancer Services Hair Loss Support, presented by Gina Beard, and again was a really emotive and fascinating kind of application in terms of what that will do in terms of the patients. And it demonstrated that 689 patients in just year 1 alone were impacted by hair loss and being treated through the project, which is there to be supported. And 58 professionals across Hywel Dda have now been trained in terms of supporting those individuals in terms of dealing with hair loss through whatever reasons that does impact them in their personal lives. We also then, the third application which came through was the Hywel Dda Arts Referral Programme, which was again looking in terms of approval, which we did so through the board as well. But balancing out in terms of the applications, what we've now got as a standing item within charitable funds is pulling projects back in to look at the impact of the funding. So we had 2 projects coming in terms of one which is an end of project report and the other was a mid-term evaluation. The end of project report was around haematology, clinical nurse specialist for Charitable and Pembrokeshire, and again showing a successful impact in terms of what the funding from charitable funds had achieved. And the second one was, as I mentioned, a mid-term evaluation report, and we had 5 members of staff from across Hywel Dda come to present in terms of their passion around the impact of the interactive singing and movement sessions for older adult mental health and adult frailty inpatient clients within our wards as well, which again, highly emotive in terms of the impacts and the stories that funding has continued to allow in terms of impact. We also had a very insightful kind of overview in terms of our investments around the funding that we hold, but I think it should be noted there are still concerns from colleagues around the table in terms of the balances held within the charitable funds accounts, which again we are looking at with colleagues, and in terms of we've asked for more detail around cash donations, about where they come from and the value and so on and so forth. But again, nothing to advise, nothing to alert, but just to provide assurance to the board in terms of how that committee and the work of the great team in terms of what they're doing.
Thank you, Ewan. We'll take verbal assurance from you in relation to the item. Very helpful. Okay, can we move on to report of the Digital Data and Innovation Committee? Maynard.
Nothing to say. This report was given verbally at the last meeting, so there's nothing to add.
Okay, so thanks very much. So we're just for approval's sake, in terms of the recommendations, we're approving the Laboratory Information Management System Programme Deployment Approach. Responding to the item committees alerting us to, note the stuff you're advising us to, and take assurance on the stuff you've assured us on. Great, thank you, Maynard. Your brevity is much appreciated. Item 25, Chair, Regional Joint Committee update. I think the papers speak for themselves in terms of what we're we're looking to achieve here. The really interesting part of the process was, although it was all interesting, but the presentation by CGI, really good, rich conversation. It kind of helps us just step into the a new space when we come to think about data. It's provoked me to think very differently about all kinds of issues around AI and actually AI assurance and security, which I think came through in that conversation. I'm not going to say any more at this stage. The papers read for themselves. So just to the board to consider the report from the joint report from the joint committee, receive identified separately on the September 25 public board's agenda. The paper articulating the set out of the cellular pathology business case and the work we intend to do in that space, and to ratify the approval and adoption of governance arrangements to endorse the direction of travel for all regional joint committee subgroups. Yep, okay. Great, okay. Let's move to committee update reports.
Yeah.
Joe.
Thank you, Chair. I'll be really brief because I think the paper stands, but just to ask the committee to approve the SRG terms of reference. Stakeholder reference group, I should have said.
Yep. Is everybody comfortable with that?
Thank you, Chair.
Great, okay. Can I move us to item 27, which is joint committees and collaboratives? Phil.
Yeah, happy to take the reports as read. I know one thing to flag, which I know Hugh is aware of, is that there is in the JCC, the Joint Commissioning Committee, there is a financial risk emerging that would impact on all health boards, but would also affect us as well. It's around the level of £750,000 for our effect. So we are obviously actively engaged in working with them, looking at ways that can be mitigated. It is a real challenge because this is right at the specialist end of the spectrum, and it's patients, our population who are seeking specialist treatment, but of course it does mean that we end up investing more of our resource potentially in the very much more specialist end of the spectrum at the cost of being unable to invest so much in prevention and health promotion. So I wanted just the board to be aware of that risk that is there, but we will bring that, of course, back through the financial report.
Okay, thank you, Phil. Thank you for that. We'll receive the update. Approve the adoption of the updated scheme of delegation. Is everybody comfortable to do that? Great, okay. That's approved. Can I ask, is there any other business? Sorry, I think we need our statutory partnerships update first.
Again, very briefly, board members will see actually increasing alignment between some of the items that you see in this paper and things that we're discussing in the Health Board. Do want to just raise one aspect, please, which is that Part 9 of the Statutory Partnership Regulations have been updated now, so the terms of reference for the Regional Partnership Board have been updated, and I've brought the new terms of reference to our Director of Corporate Governance and Chief Executive, so we will be looking at our representation going forward into the RPB, as that RPB actually increases its function in terms from government of coordination across health and social care on some really important pieces of work. So that will be coming, I'm sure, back to some future committees for further discussion.
And do we know when, Jill? Is there a timescale?
It's currently with Director of Corporate Governance and the Chief Executive, so we will take that, I'm sure, into an executive conversation, and then perhaps even by the next board there could be an update here around the Chief Executive's expectations around how we use our seats on that committee more effectively.
So just to provide assurance, I've already done the piece of work in terms of mapping what that looks like, because there will need to be a change from the Health Board in terms of membership of that. I just need guidance from the Chief Executive, and we just haven't had that meeting yet, but we could definitely bring you something back to the next
absolutely.
board chair with the terms of reference and who will have a seat at the table, and we may need additional seats as well, because I know Gilda didn't want to lose your representation from a primary care perspective there as well.
And we do report into the Strategy and Planning Committee very regularly, and that was on the basis that then Winston wanted to also have that more informal conversation around the increasing alignment on our agenda. So.
Good, great, that's very helpful. Did you want to add anything to that, Ardiana? No?
No.
Brilliant, thank you, Jill. Great, okay, so we'll take assurance that the Health Board is working effectively with statutory partners in order to meet our statutory duties. Great, okay. Can I then move us to any other business? Any other business? No? Okay, and for information, the board annual work plan, which, thank you, Joe. And date and time of the next meeting, 9:30 a.m, Thursday, the 27th of November. Thank you very much.
Going straight to trustee, I think, Chair.
Yeah. Okay, so let's go straight to corporate trustee. So, welcome and apologies. So, I'm presuming the same apologies apply for this morning, and the same people are in the room now. So there's no difference. Great, okay. Declarations of interest in relation to the items on the agenda. No declarations of interest. Great, okay. Okay, can I move us to copies?
It's the therapeutic guidance.
Yes, so item 3, I think it goes to Sharon.
Yeah, diolch Chair, thank you. So this is an expenditure request to develop sensory gardens at Prince Philip Hospital in Llanelli. It was considered at Charitable Funds Committee 9 days ago, and it's been recommended by the CFC to the Corporate Trustee for approval within the scheme of delegation for authorisation of charitable funds expenditure. There was a lot of discussion at the meeting. Mr Gareth Rees, who's the Operations Director, reported he was confident that the current proposal was viable and would provide patients with a beneficial and healing promoting environment. Although the costs initially appeared high, he assured the committee that they represent good value for money given the substantial size of the construction site, which spans 1,500 square metres, and which met the service needs as well as addressing the reported safety challenges reported by a health inspector at Wales during 2 previous inspections. The committee were asked to consider and support option B, which included the bowling green, which had been specifically requested by acute service teams who strongly advocated for its inclusion in the scheme. There was a £26,000 discretionary capital funding had also been allocated to the scheme, which introduced certain financial constraints related to the end-of-year expenditure. The scope to work with volunteers and community sector came across in the paper. There was a request to defer the work on the scheme until February 2026, aiming for better weather conditions. And Charitable Funds Committee noted that the contractor's commitment to social value and including local apprentices in the construction phase and emphasised the importance of extending this involvement to the garden's ongoing maintenance. Colleague Seagar's Horticultural Department was cited as an example and advocated for promoting skills development and wider community engagement through the therapeutic gardens. So Charitable Funds Committee considered and recommended for approval option B to the board in its capacity as corporate trustees, i.e. with the inclusion of the bowling green.
Thank you. Thank you, Sharon. Can I just say, I think it's an awful lot of money. An awful lot of money, and I appreciate it's charity's money in the sense, not ours. It just feels an awful lot of money to deliver this. Are we getting value for money? Ewan?
I think this is a debate we've had at Charitable Funds for years, it feels like, in terms of this particular proposal. And it is something which members of the Charitable Funds Committee have really kind of pulled apart in terms of, you know, the costs, because I think for us, we did feel it was expensive at the start, but we have worked very closely with colleagues in terms of looking at what those costs actually deliver, and in terms of the wider kind of circumstances, in terms of, we know materials have increased by, you know, kind of 75 to 90% in terms of cost over the last couple of years. But looking at the bigger scheme of things, and as Sharon has articulated as well, we kind of looked at the options in terms of the future sustainability of it, and the recommendation which we've kind of included in terms of utilising the experience of horticultural students at Coleg Sir, particularly in terms of the Graig campus, in terms of proximity principle, and in terms of the expertise through apprenticeships to really offer, in addition to the community volunteers that we will be engaging with. Whilst the initial cost in terms of its construction and implementation may seem high, it's mitigated by no ongoing costs, which will be extreme, as we see with other projects where there is an increase then in terms of the demands upon funds to maintain these type of facilities, where we're looking to actually utilise the skills and expertise from our community, so it's really taking the ownership of it for us going forward.
To be honest, it sells itself in that regard. So that would have been my concern, is that we're attributing quite a lot of money to deliver this change, and then my initial worry was, who cuts the grass afterwards, frankly. But everybody's offering.
Chair, we had a lot of discussion about the grass. They wanted to have slow growing grass, and but there is a robot that was meant to be intended, kind of, and as you say, it's a resource of someone mowing that grass. But
okay.
Did give my expertise on grass growing in
I'm sure
within the committee.
I would expect nothing less. Chantal, I can see you come in, and then we're going to go to Hugh.
Thank you, Chair. I was just wondering, is that the same scheme where locals had raised money during COVID for this and weren't able to fully use the funds because the increasing costs of the project? Okay, thanks. Sorry, I was just seeking clarification.
Okay, Hugh.
Yeah, Chair, it's that ongoing maintenance issue, and we've had this discussion as a charity, because of course we're here as a charity now, not as the health board, and as a charity we need assurance from the health board that maintenance will be prioritised, so we don't end up with an investment we make now that we need to reflect on again in a few years' time. So there needs to be that ongoing maintenance assurance. We'll work through that.
Okay.
But just to say that I visited this, so it is needed, though.
Okay.
When other healthcare systems that have done this have seen some real benefits for staff and patients, particularly when they've managed to get local students and population involved in doing kind of looking after the gardens. I saw it in Denmark, a very high performing system. It's one of the integral parts they felt of part of the healing for patients, but also for staff well-being. So I think it could have all sorts of indirect effects that will ripple from this.
And I think that came through in the paper. My other observation would be there are a number of inner courtyard gardens inside Prince Philip that frankly are not terribly well maintained. So it's a bit like, we'll focus on this one over here, but these inner ones, are not well maintained. There's an incongruity between these kinds of things. I appreciate that's not necessarily, as trustees, we're not here to discuss that, but it does feel to me it slightly undermines the argument that it's good for people if actually we don't do anything about those inner courtyards. And they're the same. There's not a maintenance around those contracts because they're not affordable. James, you're going to come in, and then Eleanor.
Diolch, Chair. So with my executive hat on, I do have assurance that the maintenance engineering team can provide us the assurance that we've got sufficient scope within state facilities to continue with the maintenance. So I just wanted to provide that to our colleagues around the table. Thank you.
Great, okay. Eleanor.
In one of my visits to the
Philip, I spoke to the staff where this is going to be built outside. Get the hang of it. It has real patient and people benefit. I think once it's done, we will see results in people's both mental and physical well-being from it. It's worth investing for that. I thought it was expensive. I take assurance from the comments that have been made here. And recognising we're here as the charity, I would ask, could somebody look into getting volunteers to do those other courtyards, please? Yeah, it would look so much better.
Thank you. Come on then.
Okay.
Portable.
Okay, great. Ewan?
Yeah, just in terms of, I think, as has been articulated, if we can get the volunteer structure right in terms of this, it provides a blueprint for the other gardens which are not being maintained. So I think, the answer and solution is right in front of us. We just have to make sure this is delivered and works for our community, both inside and outside of the hospital boundaries. And, as Rodri said, in terms of the grass cutting, we've got a robot to do that now, so it'll be great.
Great. Okay, thank you. I'm not going to hold my breath, but I'll set your assurance. Sharon.
Just one more comment to add, because the Therapeutic garden is for Bringolai and Mynydd Mawr, and we did seek assurance at Charitable Funds Committee that other services would be able to use it as well, and that was, so in terms of value, there's opportunity not just for those two areas to use it.
Yeah.
That's to be extended.
Excellent, and I do think there's enormous therapeutic value, but I think if they're not maintained, it has the opposite effect. It has the opposite effect. Okay, great. Okay, well let's accept the recommendation to take that forward, and I don't think I read the timescale on delivery of this.
To commence in January 2026. Yeah.
And presumably we'll all be there at the launch of it, hopefully. Great, okay.
With the trowel.
With the trowel, yeah. Great, okay, thank you very much. Thank you, Sharon. Just so, any other business? No? No other business. Date and time of the next meeting to be confirmed. Thank you very much.